we will all uh, learn from you.
So what's the process where you are in order to become a physical therapist that's licensed to practice? Is
In
it
Egypt.
X number in Egypt? Is it
Uh,
4-year degree, then you take a licensing exam? Is that
uh,
how that works?
we have a college of physical therapy. It's a 6 year, 6 years.
Oh,
Uh,
wow. Okay.
yeah, the first five only studying, and the last year is like a clinical practice. We have to take 1 year practicing, then we go to the license exam. We must
Okay.
uh, uh, get a degree on it so we can take the license. So it's 6 years.
Wow. Okay. Hmm.
We study a
Now,
lot of like first 2 years of basic science, then
mhm.
internal medicine, women health, surgery, orthopedics, neurology, and pediatrics also.
Now, do you have, I guess I'm going to use the word advanced degrees or advanced like residencies or fellowships in the area of physical therapy
Yes,
in each?
yeah, yeah.
Okay. So after one becomes a licensed physical therapist, then they can go on and do advanced clinical work
Yes,
or advanced research or whatever. Is
yeah,
that
yeah.
correct?
Yes.
Okay.
Um,
Huh.
you can take like PhD or Master of Science or yeah, yeah. There is a lot of options after graduation that we can take to like be more advanced or specialized.
What are there particular areas that you have that I guess promote specialization? Is it like
Um,
orthopedics or sports or neurological or pediatrics or what type of specializations do you all have?
I think all of that, like we can specialize in just in pediatrics, or just in orthopedics, or just in sports injury rehabilitation. Um, we even have a physiotherapist for internal medicine. So
Hmm. Wow.
yeah, we have a lot of specialties in it.
Sure. Now, if somebody graduates with their license and they pass their licensing exam, before they do any advanced specialized training, can they still practice in all those different areas?
I think yes.
They may not be that good, but can they
Yeah, yeah,
still practice?
yeah. I think yes, but there is a like internal medicine. We can't practice it uh, just in hospitals. We can't practice it outside, just in hospitals, like internal medicine. But
Okay.
specialties like orthopedics or neurology or pediatrics, yes, we can. They can work in it or work on it. Yes.
Okay. So that's pretty similar because in the United States, there's 18 different practice areas.
Oh,
So once you have your license, you can practice in any of those areas. So, as an example, I've been in sports for 50 years. If I want to get out of it and go to pediatrics, my license lets me practice in pediatrics. I may not be very good at it, but
yeah,
but my license still lets me. I mean, obviously, rarely would anybody ever do something like that, but still, um, that's interesting. And the whole internal medicine thing, we in the United States are trying to get into what you call internal medicine. We call it primary care providers.
yes, yes,
And that's been very new for us, though. I mean, I mean, people have been practicing to some degree in that area, but now we're trying to develop a subspecialization in the area of primary care or what you call internal medicine.
yeah.
So, boy, that
We
means
have
you got
the
to know a
same.
lot of
Yes.
stuff about a lot of things. So,
Yeah, I for us it's physiotherapy is at Egypt uh, kind of new. So just last like 30 years or something.
okay.
Before
Hmm.
that, there was physical therapy, but like no specialties, no one knows what physical therapy is. But in the last 30 years, yeah, to physical service. We have a lot of universities, like over 90 physical therapy universities across Egypt. So yeah,
So in Egypt alone, there's 19 universities that have physical therapy programs.
yes,
Wow. I didn't realize that. That's a lot. Yeah.
yeah.
So how
It's
many,
a kind of problem, yes, but
sure, approximately then, how many students per class that are graduated every year?
across all of Egypt, um, I'm not sure, but like 30,000 every year, and that's a problem in Egypt because hospitals and the market was not ready for all of that number.
Okay.
So yeah,
Huh.
a
Interesting.
lot of physiotherapists, a lot of physiotherapists.
Hmm.
New
Sure.
universities are opened recently. So
So what would the class sizes of each of the universities? I know it varies from
yeah,
university to university, but what's an average class size at the universities if you just had to guesstimate?
like in Cairo University, it's almost 2,000 students. But in my
Okay.
university, I'm in a university called Ahram Canadian University. It's almost 400. So it varies a lot between if it's
Okay.
a governmental university, it will be a lot of students. But
Okay.
if it's a like I don't know what it's called, but not non-governmental university, it's just
Sure.
many hundreds, like 300, 400.
Okay.
Yeah.
Now, Basmuth was the original person who contacted me.
Yeah.
What is her role, or why did she contact me versus you? Because you and I are spending more time together,
Yeah.
which is fine, but I was
That
just curious.
I actually don't know, but uh, she's specialized in 3PT at I actually don't know,
Okay,
but
that's fine. Okay. All right. It's about 9:58 here.
yes,
So as you said, whenever you want to kick things off, you just let me know.
yeah, بسملة.
Yes.
هو في دلوقتي لايف ستريم
اه يلا.
فنبدأ.
اه
Okay. So I will start with a brief introduction and yeah. So welcome everyone to Street BT. I am Omar Shalabi, and in the world of physical therapy, there are names you see in textbooks, and then there are the names that founded the journals those textbooks are based on. Today, we are joined by a man whose career spans over 50 years of clinical excellence, from serving as a U.S. Marine to working the sidelines of 4 different Olympic Games, and a decade with the New Orleans Saints. His impact is unmatched. He's a Hall of Famer, the co-founder of GOSPT, and a fellow of the American Physical Therapy Association, one of the highest honors the ABTA can give, a distinction held by a very few people in the world. And outside the clinic, an Ironman triathlete, a marathon runner, and a black belt in karate. It's a profound honor to have him here today. So please give your full attention to a true titan of our profession, Dr. George A. Davis. The floor is yours.
Thank you, Omar. It's definitely an honor and a privilege to have the opportunity to be invited to participate and share information with many years of experiences with some very popular topics that are going on in the areas of physical therapy today. When I was first invited, I was actually initially invited to describe more about the concept of sports physical therapy. So I'm going to take just the first few minutes and talk about the overview concept of sports physical therapy rather than just focusing on ACLs and hamstrings, because obviously practicing as a sports physical therapist is certainly more comprehensive than just rehabbing those particular types of injuries. The objectives of our presentation will follow this outline. So we're going to talk about the sports physical therapy competencies initially. Then we'll go into ACL injuries and some examination techniques, into some of the treatments, particularly focusing on the changes that are occurring with surgeries now. It's rather interesting, I think, that I've been practicing for a long time. And in the first few years in the 1970s, there were some things going on with ACL surgeries and changes and things of that nature, which we'll review when we get to that point. Then for the last probably 30 years, it's been pretty much just a matter of changing where they're putting the ACL inside the knee and the different structures like that. However, recently there have been many, many changes with looking at non-surgical treatment, the bear technique, the cross bracing technique, so using an internal brace. So there's some of the things that we'll talk about when we get to that point. Then after we talk about some of the surgical procedures that are being used, then we're going to go ahead and go through some of the implications for the rehabilitation. So prehab, what about the healing process? Then we'll go into a phase-based approach. Everybody has their own approaches, and this is just another example. And then what are some of the criteria that we can use for return back to sport? So again, throughout the presentation, at appropriate times, I have some slides that'll come up with questions. And if at that time there are any questions that people would like to share, then Omar will basically moderate that session, and then we'll just move on. So once again, I am George Davies. I'm a professor of physical therapy, and I'm a rehab specialist at the sports medicine and athletic department. That means what I do now, and I'm having as much fun as I've ever had in my entire career, I only rehabilitate all the Division I athletes throughout the university. And as you can see, I'm at the University of Texas, Rio Grande Valley, which is in the southern part of Texas. It's a Division I, an R1, which means we have a lot of research money, 35,000 students, and we have about 20 different sports. I've also started a residency program back in Wisconsin, so I also continue to help out and mentor there. So that's the location. Everybody's sort of familiar with the state of Texas. Well, that's the state. And way down there at the bottom where you see the star is where the Rio Grande Valley is. It's right on the Rio Grande River, which is right next to Mexico. So once again, it has a lot of old historic buildings there as well. And again, this is their athletic training room where I actually see all the different sports injuries in the athletes in the training room. And this is where we get the athletes ready to go out to practices. In the very back there in the left-hand side, we also have an underwater treadmill that when it's computerized, as you can see in the front, so we can do some pretty decent rehab with the different athletes at the university. Full disclosures. Whenever you do a presentation, you must always identify disclosures. So I am the associate editor of Sports Health. I was one of the original founders and one of the original associate editors in the area of physical therapy for that journal. Interestingly, as you can see, that journal now has about 70,000 subscribers throughout the world. And it's actually one of the largest circulation sports science, sports medicine journals in the world. Furthermore, as you can see, it has over 3 million downloads a year. The impact factor is also increasing on a regular basis year after year. So again, that's one of the I think, premier things that we're able to educate masses. Now, the interesting thing, if you look at the title, Sports Health, but you look at the subtitle, a multidisciplinary approach. And I think that's really the key to the journal, because the journal is sponsored by the American Academy of Orthopedic Surgeons, which are all the orthopedic surgeons involved in sports medicine, the AMSSM, which is the American Medical Society for Sports Medicine. they're physicians that are interested in sports medicine, but they're not necessarily orthopedic surgeons. The National Athletic Trainers Association, and then also the Sports Physical Therapy Association, or now it's called the American Academy of Sports Physical Therapy. So the point is that all of those different professional organizations contribute to the Sports Health Journal. So it does truly provide a multidisciplinary approach to taking care of the athlete and people in physically active activities. So I've been a member of this society for well over 50 years now, and it's been fun to be actively involved from the very inception of the program. As Omar mentioned, I'm also just proud to mention that I'm a veteran 57 years ago. And if there are any other military veterans from whatever country you're in right now, I want to thank you for your service. And that's what helps keep many of the countries free today. All right, so now back to our outline, and we'll come back to this each time we switch to a new category and topic. So the first thing, as I said, when I was originally invited, it was sort of the focus on sports physical therapy and the competencies. So I just want to spend a few minutes talking about this before we get into the hot topics. At the end, it's not listed there, but the other thing that we discussed was also talking about hamstrings. So I also have a presentation on hamstrings within a very interesting recent case study that I have. So after 4 hours, we should be able to get to that information as well. So starting with sports physical therapy residency programs. Now in the United States, today, it's usually a 4 years of undergraduate bachelor's program and then a 3-year DPT program. So the physical therapists in the United States all graduate now with a doctor of physical therapy. There's a variety of hybrid programs going on where it's maybe a 3+3 or a 4+3. So there's variations. At any rate, one graduates from their university that's accredited, then they basically have to pass their licensing exam. And where I want to go now is the concept of sports specialization. So as you can see, there's 84 sports residency programs. 7 of those are also at a fellowship. That's beyond the residency, doing essentially game coverage at Division I universities, and there's 5 that specialize in upper extremity athletics. Now, this is a busy slide. I know that. I'm going to get past this in a second and go through each of these very briefly. So these are the ABPTS, which is the certifying board, for the SCS, which is Sports Clinical Specialist Board Certification. And I've been that for over 30 some years. But at any rate, these are the different areas. So I want to go through each one of those just briefly and show you the emphasis. So the first one is make evidence-based clinical decisions for rehabilitation and return to sport. That's what we're going to be spending the majority of today talking about. But the point, as you can see, the examination, evaluation, diagnosis of, say, in this case, ACLs and hamstrings, it really is only about 20% emphasis of what a sports physical therapist really does. So as you can see, that's all predicated on the prognosis, the interventions, and the outcomes. And that way you can look at the patient through the entire spectrum, from the initial injury with the exam, evaluating it, coming up with the diagnosis, whatever their prognosis, to the interventions and the outcomes. And that's basically scenario-based examples are provided in discussion and practice with the actual testing and the metrics. So that's one of the parts of the board certification exam. So again, here you can see, looking at the different things of this incorporates, as we said, the outcomes, which includes things such as current return to sport testing. What are some of the proposed return to sport testing? And then how does that deal with participation back into the sport and performance enhancement? And we'll be talking about that as the last part of our presentations with the ACL today. The second thing that's critically important, as you can see, is administering emergency care. To be eligible to even apply to a residency program, one must first take and be certified as a emergency care first responder, meaning that they've had good, quote, on the field practice. So if an injury occurs, again, you know what to do with acute injury and illness management. And that's about 15% of the emphasis in sports physical therapy. As we all know, when we work in a clinic setting, it's not always a really acute environment where you have to really react quickly and do the right thing. We always do the right thing, but I mean, we don't have to be under a lot of stress with an emergency situation. But that's one of the unique things of the sports physical therapist that really differentiates them from, I'll say, traditional physical therapists, if you will. And again, that's where we would have reality-based sports emergency situations. And that way the clinician has to go through practice and clinical decision making and have a good emergency action plan. So again, one example would be in hockey. If somebody were injured on the ice, how do you get a spine board out on the ice? And again, not only is it important for the athlete, but you have to be careful lugging a spine board out on the ice, getting there and then spine boarding them. So that's the second area of significance. Thirdly, again, recognizing medical surgical conditions that occur in sports, and then how do we adequately approach that, both from, again, the emergency situation, they've had the surgery, now we're going to deal with them after the surgical intervention. And as we all know, there's numerous surgeries, and we'll talk about those relative to the ACL in a little bit. And again, there's in-depth descriptions of the medical conditions that occur, all the way from things like heat stress problems. Every year in the United States, unfortunately, some athletes die with heat stress and problems. Things such as different spine injuries that can occur. So there's a variety of things of medical and surgical conditions that the clinician needs to be aware of. Furthermore, looking at things like injury prevention and epidemiology. So knowing what the injuries are and knowing the epidemiological incidence, then that may help us, again, develop some preventative conditioning programs. And that's where, again, things like the Certified Strength and Conditioning Specialist by the National Strength and Conditioning Association is a very important credential for a sports physical therapist to have. Because again, physical therapists are good when we're dealing with patients and post-injuries, post-surgeries in an acute rehab type of setting, and in the early phases and the intermediate phases. But again, a lot of physical therapists, quite honestly, don't have a lot of experience and training in the strength and conditioning and the performance enhancement areas. And there's actually published research that shows that many, again, physical therapists and physical therapy students, when they've been given an exam, and this is published in the Physical Therapy Journal by Handerley, that they don't do very well in passing some of the written exams, which means obviously if they can't even pass the written exam, they're not going to be able to apply it to a patient. So at any rate, this is another important area. Injury prevention, as well as the other end of the spectrum, is the performance enhancement phase. And just as everybody is certainly familiar with the FIFA 11, how effective that has been in preventing injuries. And then you can just see one slide as just an example of the prevalence of some of the different types of injuries that are present worldwide with the epidemiological incidence. Next, again, is, as I alluded to, it's really a continuum. So now going to the continuum from rehab into that last phase of not only return to sport. A lot of people after an injury or surgery return to their sport, but not very many people return to their pre-performance level of their prior performance. So again, looked at different metrics. So here we look at the sports performance enhancement, and that comes down to a lot of the applied sciences and the human performance area, and looking at some of the sports science information and getting into how do we really do that? Are we using good metrics? Are we using things like GPS or IMUs to help us determine what the needs are of that athlete so we can develop specificity performance enhancement programs? So they're just some examples. Again, so the whole area of sports science has just snowballed recently, particularly with everything going on with AI and all the different changes, technological advances that are occurring. So again, as a part of that, as we all know, is the mindful sports performance enhancement, the mental training, mental conditioning, etc. And the reason that's also important, as we all know, again, that doing PROs or patient-reported outcomes are very important, but that's only part of the battery of testing. We need to look at patient-reported outcomes, but we also need to look at some of the objective testing and then a performance enhancement type of specificity testing. Along with the PROs, one of the areas that we know very important with ACLs is the area of kinesiophobia, or fear of returning back to sport and getting re-injured. So that fits under the whole idea of the mindful sports performance enhancement and part of the spectrum of what a sports physical therapist really does. Lastly, of course, is some of the professional roles and responsibilities, being aware of all the different aspects, looking at the different things such as counseling, educating the patients, what are the effects of ergogenic aids, nutrition, sleep, and then being familiar with the current, I'm going to say, state of the art with a lot of this, looking at things such as we mentioned, how can we enhance performance, not only through some of these variables of sleep, imagery, dyad training, biofeedback, some of the psychosocial interactions, not only with the team members, but now with coaches, with agents, with family. It's very complicated, but this is, again, another area that falls under the professional responsibilities of a sports physical therapist. When we look at some of the sports, I'm going to use the word basics, we can look at the whole area now of sports psychology has exploded. The training and performance, again, the performance enhancement, looking at treating the sports injuries, and then obviously hopefully the prevention with sports safety and preventing the occurrence of some of those injuries. Again, we're very fortunate that we've had a residency program that we interestingly founded, the first sports physical therapy residency program in the United States. We founded that actually 30 years ago, and I was the original director and the original founder of that. And again, this fall in September, we're actually going to have our 30th anniversary reunion. So we're going to have several of the different residents that have graduated, gone on to excel in different areas. For example, one of the residents went on and became an orthopedic surgeon. Several have gone on and gotten their PhDs, and now they're also teaching in universities. So there's a variety of very successful individuals. Now, the other thing, again, at that clinic where I worked for 30 years, and I still go back in the summers and mentor the residents, you can see there's over 500 physicians in that complex. And again, we actually contract out with about 45 high schools, and I've been doing that for many years, cover over 1,700 sporting events a year. So there's about 10 full-time athletic trainers on staff, and they go out on a regular basis to the schools. And then those that are also dually credentialed as a physical therapist and a sports physical therapist, a PT SCS, then they help, or some of us are also PTs, ATCs, certified athletic trainers. So we all have contributed there, but as you can see, high volume. So you have an opportunity to see on the sidelines of the games, the epidemiological incidence of what's the mechanism of injury, go on the field and do the acute care. And that's what I said. It's not all about the rehab, but true sports physical therapy is also very important at the other end of the spectrum with the prevention. And then if it does occur, an injury, then we have to be able to intervene. Well, the other thing that's interesting as we look at that, the board certification pass rates, if you look on the right-hand side, these are the different specialty areas. Interestingly, the sports physical therapist has the lowest pass rate. Now, there's two different ways that physical therapists can become board certified specialists in sports physical therapy. The first way, as you can see, option A at the top, they have to have clinical experience of a lot of hours doing patient care within the previous 10 years. Usually they want at least 2 years of practice. So that's about 4,000 hours of practice seeing sports-related injuries, not just general outpatient ortho. The second option is going through a residency program, as I've been explaining. But if you look down at the bottom, you see those who actually do it with their clinical experience have a very poor pass rate, only about 65%. Interestingly, even those who do a 1-year residency, their pass rate is only 86%. So we average that. The overall pass rate's only 73%. So it's not an easy exam is the point. So what I'm very proud to announce, however, our residency program for 30 years has a 100% pass rate first time on that exam. So we're very proud of that. But again, the reason it's all based on looking at the comprehensive approach of what a sports physical therapist is. And it's not just rehabbing ACLs or hamstring injuries, which is what we're going to talk about for the rest of the time. So, as I indicated, we're going to have our 30th anniversary this October, which is really exciting because I haven't seen some of these residents for years. And it'll be a real privilege to be able to interact and see them again and see how successful they've all been. So at this point, again, I know that's just an overview of sports physical therapy. I don't know if it's even worthwhile to start any questions at this point, because I know we want to get into the meat of the matter with this ACL stuff, because that is so popular right now. But if there are any questions, we can take those. So, Amar, do you have anything right now? If not, I'm just going to keep on cruising.
All clear from the chat. So go ahead, Dr. Davis.
Okay. All right, let's move on. Now, let's go ahead and start talking about this ACL injury and what do we do in the initial phases. All right, so ACL, as we know, is one of the most popular things. Hundreds of thousands of ACL injuries occur in the United States, millions worldwide, and again, hundreds of thousands of ACL surgeries, a variety of types, as you're going to see. So as we all know with the ACL, that the ACL typically occurs when we have a two-planar injury. It's usually a frontal plane valgus with a transverse plane rotation. That's why when you do an exam of the knee, doing the gold standard Lachman's test is the gold standard, but really your Lachman's test only checks sagittal plane motion. It doesn't check the transverse plane motion. So that's why doing something like a pivot shift test or the jerk test is also critically important. So that's the mechanism of injury that we're all familiar with. And about 70% of those, by the way, are non-contact. Whereas here's an illustration of a contact injury. So you can see in this case with American football, the shoulder is hitting on the lateral side of the knee. And again, looking at that, you're probably going to have an ACL, MCL injury because of the valgus forces. And consequently, that's going to be your contact injury. So once again, previous slide, about 70% are non-contact, about 30% are contact type of injuries. Now, again, watch her position of her left knee. You can see not only the position, the valgus and the rotation, but also look at the trunk. So we'll see several examples. There's another valgus rotation. Watch the hyperextension recurvatum test right there. So planting the knee and causing the injury. There's your valgus internal rotation. Left knee, valgus internal rotation. That's actually a knee dislocation. ACL, PCL, MCL. And look at the patella. It's actually a patellar dislocation as well. Now, this guy has done this thousands of times, but watch how quickly this occurs when he lands. It literally occurs in milliseconds right there. So your ACL literally occurs in milliseconds. So it's very difficult to really train that quickly enough in rehab to prevent something like that from occurring. Interesting here, watch the guy when he walks back. Watch his knees. Auriculatum hyperextension. Again, there's your hyperextension valgus in that position. Again, see the similar mechanism. Last example, not having the foot under your base of support. So watch where her lead leg is. So she plants that foot way out in front of her and tries to rotate. And that's your typical mechanism of injury right there. If you can keep the athletic stance and keep your weight bearing underneath of your center of gravity, that's one way we can train, if you will, to try to minimize the non-contact injuries. So that's just an overview of some of the examples of the mechanisms of injuries. Again, 70% are non-contact. Now, after the injury occurs, that's what you see. You see a huge, again, obviously, here's the inferior pole of the patella, here's your infrapatellar fat pads. So your joint line is right here. But the important thing, when you see the swelling, don't just look at the knee joint, but remember, the knee joint is the largest synovial joint in the body. And it goes about 2 or 3 hands distances above the knee joint. So your suprapatellar capsule is way up here. So when you look at the top of the patella, where the quads come into the superior pole of the patella, there's usually an indentation right about there. Well, obviously here you see a big swollen area. So that's the typical effusion that occurs, because once you rupture the ACL, then the genicular arterial system provides the blood supply and it starts to bleed and consequently creates the intra-articular effusion. So that's what that knee looks like. As we also all know, whenever you have an effusion in the knee, that creates an AMI, arthrogenic muscle inhibition. We'll get to that a little bit later when we start talking about the rehab. But again, that's a problem. We have to get rid of that effusion. Once again, everybody treats that differently. Some people will actually, some of the physicians will actually aspirate that area, and others will not. We'll use a variety of modalities and different things that we're all familiar with, and we'll talk about that in the early phases of rehab. Again, how do you treat it? So we'll elaborate later, but in the old days, as we all know, it's interesting, we used to use the RICE formula, where you would use rest, ice, compression, elevation, or some would put a P there, protect the area. Then it went from RICE to police. Protect, optimal loading, loading the area, ice, compression, elevation. And now it's segued to peace and load. Protect the area, elevate the area, avoid anti-inflammatories, compress the area, educate, load the area gently in the proper places, optimization of the exercises, vascularization, and exercise. Now, the one thing that they have changed is away from this, but again, regardless of what your philosophy, I still, maybe I'm old school, but I still think there's a major role for cryotherapy or ice with patients nowadays in the acute phases. Now, once again, just to show you how long we've had an interest in the knee, here's an article that's almost published 50 years ago. So 48 years exactly. But again, we actually wrote this article a long time ago, and one of the prominent physicians, Dr. Robert Larson, who was my co-author. But what's interesting, Dr. Larson, now we know one of the hottest topics in the knee is the concept of rotary instabilities. And that's why they're doing the lateral extra-articular tenodesis, or the LEPS, the lateral articular procedures. At any rate, Dr. Larson is one of the individuals who first described the concept of rotary instabilities. Dr. Slocum and Larson were the first to publish in the Journal of Bone and Joint Surgery back in the 60s the concept of the rotary instabilities and their importance. It's interesting, back in the 60s, 70s, 80s, we spent a lot of time dealing with that. Then, quite honestly, in the end of the 80s, the 90s, and the early 2000s, there was not a lot of emphasis on that. Now, things come full circle, And as I said, it's probably one of the hottest topics right now on the knee, both from the exam as well as the treatment and the surgeries. And that's, as I said, that's where they're doing the LETs and the LEAPs on as part of the surgical procedures. We'll get to those in a little bit. So from the exam standpoint, again, we start looking at that. We've also written a long time ago, again, as you can see the date, many, many years ago, an entire book on rehabilitation of the surgical knee. And here's a recent article, again, just a couple years ago, diagnostic accuracy of the physical exam test for ACL. And again, as you know, systematic reviews and meta-analyses are the highest levels of evidence where they pull all the different stats from the different articles and come up with some conclusions. So what were their findings? Well, the Lachman's test, as we all know, is our gold standard test. And again, you compare the amount of translation, obviously, to the other side, and you compare it to all the other knees that you felt. You have to put the knee in about 20 to 30 degrees, because if it's in full extension, it's the screw home mechanism or the closed pack position. Obviously, you're not going to get much motion. And if you flex more than that again, then you're tightening the anterior band and not the intermediate or the posterior lateral bands. So about that 20 to 30 degrees, and then you stabilize the thigh, as you can see there. And then with your distal hand, you pull in a straight sagittal plane. So as I said, it's the gold standard test, but frankly, it only measures the sagittal plane motion or the anterior translation. And as you can see, anywhere from 2 to 3 millimeters is pathognomonic of an ACL. And again, you're also feeling for the end feel. So we all talk about different end feels in physical therapy. So it's the translation and your end feel. There should be a good firm end feel if it's intact. If it's not, then you'll have a soft or a squishy type of end feel. You can see, obviously, there's numerous studies, and you can see the sensitivity specificity of that test. Obviously, one of the best tests that we have, and that's why it's referred to as the gold standard. But one more time, remember, it only measures sagittal plane motion, and an ACL injury is really two-planar. It's not only sagittal plane, but it's also transverse plane rotations. So here again, looking at the highest diagnostic accuracy, the Lachman's, the anterior drawer test can also be performed, as you see in the right side here. However, a couple points of emphasis. One, make sure the knee is not more than 80 degrees of flexion. The reason for that, if you flex the knee more than 80 degrees, what happens is the meniscus migrates posteriorly in the joint line. Medial meniscus about 6 millimeters, lateral meniscus about 12. They end up getting wedged in the back of the knee and cause a chalk block effect. So consequently, you could literally have an ACL that's ruptured, and in that position, as you pull, the chalk block effect from the meniscus posteriorly wedged between the tibia and the femur would negate anterior translation. Furthermore, the other limitation of the anterior drawer is as you flex the knee like that, you're only checking the anterior band of the ACL because the intermediate and the posterolateral band are put on slack with flexion. So again, you could have half of the ligament injured, and with an anterior drawer test by itself, you may not even be able to pick that up. Then the other test down here is the lever sign. And again, this is, again, straight sagittal plane. All three of these are straight sagittal plane. So you put your fist underneath the proximal calf area, push down on the femur, and if the ACL is intact, then the heel will lift off the table. If the ACL is not intact, as you push on the femur, there's no connection between the femur and the tibia, then the foot will not lift up off of the table. And then lastly is your pivot shift, which, as I said, is sort of one of the gold standards. And the reason it is because, again, remember, an ACL injury is both a sagittal plane and a rotational or transverse plane injury. So again, there's your lever test illustrated. So again, the top illustration demonstrates a positive finding that the patient's heel does not lift off the table. Whereas the bottom, you can see as they push down on the femur, the heel lifts off of the table because the ACL is intact. Again, you see there sensitivity, specificity. So if you have somebody who has a very big thigh and it's hard to grasp it, then this is a good test to use because it's a little bit easier with hands. Again, when you look at an ACL on imaging, that's what your normal ACL should look like. The darker the color, the more vascularity, the better the quality. There's a torn ACL, so you don't see the fibers in the mid area. The other thing I just want to mention that's really important from a rehab standpoint is this. This, when you see this on the bone, is a bone contusion. And again, every ACL, 80 to 100%, based on the literature, will also have because of the pivot shift phenomenon that causes the injury, that also causes a bone contusion. So when you have a bone contusion, that causes significant complaints of pain. The hyaline cartilage itself, remember, is not innervated, but the subchondral bone is highly innervated. And if you have that type of a bone contusion, that can oftentimes be the limiting factor. So once again, your normal ACL on the top, there's your torn ACL on the bottom. So that's what it would look like intraoperatively. So again, there's different variations that can occur. It can be at mid-substance, it can be an avulsion off the femur, which is called a Sherman type, and there's different variations of that. It could be an avulsion off of the tibia. So again, there's different variations, and they're going to treat them differently based on the surgical procedures. So there you can see, again, on the left, an example of a partially torn ACL. You can see all the hemorrhagic bleeding. On the right side, it's a chronic one because you don't see the redness or the bleeding that's there. So that's more of a chronic example. So we have that torn ACL. So as I said early on, for 30 years, there were really no major changes in the surgery and rehab of ACL injuries. Surgeons made minor changes in the position of the tunnels and all these things. PTs, again, we tried accelerated rehab, saw an increase in re-injuries, then we started to go longer. So the times also vacillated back and forth. However, recently there have been some changes which we'll segue into next. Once again, any questions? Most of this is pretty straightforward, but we need to start with the basics to understand where we're heading. Omar, any particular questions, or can I just keep on going?
Here's a question from the audience. Habiba wants to know can someone get injured while jumping during playing basketball and he landed without the known ACL mechanism happening? There was no edema, it was locked, and he made MRI and turned out to be full tear.
If somebody actually lands playing basketball and they land and they rupture an ACL and there's no bleeding, then that's a pretty rare incidence. I would suspect what may have happened is that player may have previously injured that ligament. It may have been stretched. The genicular arterial system may have been compromised previously. There was not a lot of blood supply to the ACL. And then when they landed and they ruptured it totally, then they did the MRI and there wasn't a lot of an effusion. Then that probably, in my mind, would maybe be a pre-existing ACL injury, and the ACL had been compromised without blood supply. Because I would say 99% of injuries with ACLs end up having a pretty significant effusion, as you saw in that one patient. So that's a pretty rare example that was described. Obviously, there's always exceptions to everything we talk about. But I think that may have been the example. That may have been why they landed, because they didn't have a fully intact ACL that had been previously injured and didn't have a good blood supply. It had been previously injured. Then when they landed incorrectly and they had that valgus mechanism and rotation, then that just totally tore it all the way through. But there hadn't been a good blood supply there, and that's why they didn't have an effusion. That's my guess. But that's pretty rare. It's pretty rare. So. All right, should we move on?
Yeah, no more questions for the moment.
Okay, now let's get into the treatments and the surgeries. This is interesting. This is where so many things are happening. Look at this laundry list. Non-surgical treatment and rehab, the Canaan trial, cross brace technique, using autogenous BTBs, STGs, quad tendons, contralateral BTBs, now adding the ALL, the anterolateral ligament, or a lateral extraarticular tenodesis, or a lateral extraarticular procedure. These are all the current trendy things going on. Allografts aren't used very often in sports. Primary repairs using what's called a bear, and then grafts using an internal brace. So most of these things have only occurred in the last decade or so. And as I said, for a long time, about 30 years between about 1980 to 2010, there haven't been a lot of major changes. All of this has been happening in the last 10 years, other than your traditional autogenous BTBs, hamstrings, et cetera. So let's start talking about those. Now, one of the things that's really interesting is this, the Canaan trial. So as you can see from the title of this article, delaying ACL reconstructions and treating with exercise therapy alone may, and we always use that word when we want to be covering, to make sure we cover everything, alter prognostic factors for a 5-year outcome and exploratory analysis of the Canaan trial. So again, this was published. It's a non-surgical approach to treating. And here's the Canaan trial. And this is just an infographic that describes it. The patients they use, again, had ACL healing 2 years on an MRI. And again, they felt that there was better patient outcomes compared to those that obviously didn't have a healing response. And again, that's a published paper in British BJSM. So that's an example of one of the trends. Now, the other new trend that's happening with non-surgical is this idea of healing of acute ACL ligament ruptures on MRIs, but they're doing non-surgical management using the cross brace protocol. And again, as you can see, they're the authors down at the bottom. It's named after the father of Merv Cross, and then Tom Cross is the orthopedic surgeon's son. So again, the whole idea with this cross brace technique is you can see the rupture of the ACL. The presumption is that when you put the knee into that flex position, it approximates the stump ends, so therefore they can end up approximating and healing together with scar. So that's the whole idea of being able to approximate the stump ends and therefore allowing the ruptured ACL to go through the healing process. Then they go through the cross brace technique, which, as you can see, the knee is put in a brace from 0 to 4 weeks. It's kept at 90 degrees of flexion. Then about every week thereafter, they increase the range of motion. So again, at 5 weeks, it goes 60 to 90, 6 weeks, 45 to 90, 7 weeks, 7 to 30, 8 weeks, 20 to 120, 9 weeks, 10 to 120. And after 10 weeks, full range of motion. And at 12 weeks, they remove the brace. So that has been published. And here again is just the infographic that shows the surgical stabilization and then the cross brace protocol. And what they're looking at, again, one more time, is looking at some of the different MRI results. So I just added a couple of slides. This one's not in your handout. I just added this because the reason I added this one is because of the next slide that's going to come up. Here, the development of MRI-defined structural tissue damage and the healing process using the Canaan trial, or similar to the cross brace non-surgical approach. So from the actual ACL tear to the treatments non-surgically to a 2-year follow-up looking at the MRI. And the MRI scans, again, all look pretty good. So that's what the Canaan trial shows. I just added this study actually this morning because this was just published this week. Non-operative management for the ACL ligament tears may result in ACL fiber continuity on follow-up MRIs. However, this finding does not correlate to restored knee stability, as joint laxity often persists. So once again, even though the MRI showed continuity when they looked at arthrometer testing and things like that, there was still a lot of laxity in those ligaments. So I think that really shows the conclusion at the bottom. Although MRI may show continuity of the ACL fibers with non-operative treatment, the KT testing, which is a device you use to check the integrity and the stability of the ligament, shows that there's a lot of joint laxity. And I think the take-home message here, and the reason I included this slide, this was just published this week in Arthroscopy Journal, which is one of the better Index Medicus journals. But again, I think the most important take home from this slide is we don't treat an MRI, we treat the patient. So let's always keep that in perspective. So there's a lot of controversy on some of the cross brace and the Canaan trials and all that. But here's a good, again, a follow-up with over 351 patients with a systematic review looking at 7 different studies that have addressed this concept. So again, I'm not saying it's not working, but what I am saying is we need longer follow-ups and more research to really validate the efficacy of non-surgical interventions. Even though MRIs look good, as it says here, joint laxity still persists. And that's what you don't want to do, is turn an athlete back to a high-level sport that still has residual joint laxities. So again, it comes back to that early season. Do you do immediate surgery? Do you try to rehab and brace them and get them back, or whatever? Well, again, we've already talked about the first couple things. So now the trend, again, at least in the United States more so, is to doing an ACL reconstruction. The gold standard ACL reconstruction has been using the patellar tendon. Bone from the patella, the central third of the patellar tendon, about a minimum 8 to 10 millimeter graft. If it's less than 8 millimeters, it's too thin and it's not going to provide stability. So again, that's an important concept. So if it's a smaller patient or a petite patient, they may not have a 10 millimeter graft where you can harvest the central third, or about 8 to 10 millimeters, then they may have to opt for a different graft. But at any rate, this is still the gold standard. In America, with the NFL, American football, 31 of 32 physicians, this is their graft of choice for football, which is the highest contact sport. So they do, once again, a bone plug, central third patellar tendon, and a bone plug here. So that way, when they put the graft into the femoral and tibial tunnels, you end up with bone-to-bone healing. And that's a really important concept to be able to facilitate maybe some advances with rehab. Now, the second choice that's been used frequently and is the most common in Europe is using hamstrings. Usually they use the semitendinosus gracilis, or an STG. And then lately, over the last decade in the United States, they've started using the quad tendon. Initially, they actually took a bone plug here and the soft tissue. So that was a hybrid graft. So you had bone fixation on one end and soft tissue fixation on the other. Again, that caused some patellar fractures. So now pretty much all the quad tendons are soft tissue grafts. So once again, if you have a soft tissue graft here, a soft tissue graft here, when you incorporate those soft tissue structures into the femoral and tibial tunnels, it takes longer to heal versus bone-to-bone healing. So that's something else that needs to be kept in mind when we start looking at graft choices. So there again, you can look at the ACL, and here you see the 2 bundles that I referred to, the anterior medial bundle and the posterior lateral bundle. Some actually say there's an intermediate bundle in there, but again, there's at least 2 bundles. And again, as you can see, if you flex the knee, you're tensioning the anterior medial bundle, but the posterior lateral bundle goes slack. So that's the limitation of your anterior drawer test, along with the wedging effect of the meniscus. All right. So with that, again, they're going to use arthroscopic surgery now to do the procedure. And again, there's only a couple of the arthroscopic portal sites now, maybe a small incision depending on where they harvest the graft. But once again, here's the normal knee. You can see the quads coming in, a little bit of an indentation there where the quad tendon inserts into the superior pole of the patella. But here you see the swelling. Look at that. That's the suprapatellar capsule. and that's the effusion that occurred from the injury with the genicular arterial system, caused the bleeding, and then also now secondarily to the surgery, that's going to cause an effusion with the drilling and everything else that they're doing. So there you go. One more time, you can see the amount of the swelling that's occurring. So your normal knee, inferior pole of the patella right here, tibial tuberosity. That's if they harvest the bone, they're going to have a small incision there. Again, the arthroscopic portals. So that's how they're going to now put the surgery in. So they do the tibial tunnel, femoral tunnel. We used to drill more vertical grafts at either 1 or 11 o'clock, but that was a vertical graft. That was great to minimize sagittal plane translation. So your Lachman's test was normal. But with a vertical graft, that did not control the rotational component. So now, as you can see, instead of putting the graft vertically, as you can see, now the graft is basically not quite horizontal, but instead of being over at up here, let's say 12 o'clock at the top, 11 is here, 10 is here, 9 is here, it's over toward the 10 to 11 area. So that way it stabilizes and replaces the neutral footprint of the normal ACL. I mentioned the size. Again, typically you want a minimum 8 millimeter, but a 10 millimeter graft. So this is a sizer. So when they harvest that graft, they check it here to make sure it's large enough. Otherwise, if you're down here to a 7 millimeter or lower, then it's not going to be strong enough to provide the stability to the graft. There's all types, as we just mentioned, bone, tendon, bone, all soft tissue where they suture it together. So there's a variety of grafts. That's the graft preparation that they do on the back table as the surgeon is preparing the knee. So just another example of the different types of grafts that can be used. If you notice, this is an STG, it's longer, but by itself, it's usually too small. So they usually double that or triple that, or some even quadruple the STG grafts, depending on making sure they get a thick enough of a graft that's going to be stable. Flip side, you don't want to get a graft that's too big, because then it would encroach on the notch of the knee and cause an impingement inside the knee. So again, that's the part of the art of the surgery from the docs. So there's your example of your B bone, central third patellar tendon bone. So BTB. And there's your fixation. So they put the bone into the tibia and use a screw to basically force the bone plug against the tibia. And as you can see, different ways to fixate it. Some use buttons, some use screws, whatever. They fixate the bone-to-bone healing here. So that's the advantage of your BTB. It's probably the most stable of all the grafts. There's an example of looking at the ACL being inserted into the notch of the knee. The second graft, as I said, which is the most popular in Europe, is where they take, again, the semitendinosus and the gracilis tendons, and they're going to harvest those. Here you can see they basically have harvested them. Some actually leave them attached to the tibia, then drill through the tibia, through the femur. Some will separate those and take them out. And as you saw previously, put them on the back table, prepare them, suture them together, do whatever. And that's the graft preparation. And there they are doing the actual surgical procedure. And again, there's a variety of ways that they do that. As we said, they can use different things such as a bone plug, the BTB, or if it's a soft tissue graft, they'll do other things. The other thing you want to look at, again, at the end, is you can see that the graft is in the tibial tunnel and the graft is in the femoral tunnel. And if you notice, it angles to the side, which is where the footprint of the native ACL is. And that way it stabilizes your transverse plane rotation as well, besides the sagittal plane motion. So that's an important consideration. Versus, as I said, in the old days, we used to go vertically. That created good sagittal plane stability, but frankly, it probably facilitated transverse plane rotation. And then last graft that's popular now in the United States is now becoming the quad tendon. This was when they first started. They harvested a bone plug from the superior pole of the patella, but there were some incidences of more patellar fractures. So now the majority of people harvest the actual tendon itself as a soft tissue graft. And you can see, again, this is basically the confluence, if you will, the parts of the quad tendon. So they're going to harvest the quad tendon there. And then again, now they do the same type of drill through the tibia, through the femur, but that's soft tissue incorporation again. All right. So there are some of the current state-of-the-art surgical procedures that are being used that are, I'm going to use the word more, the traditional surgeries. We're going to segue into some of the new, now innovative types of things that are being done. But at this time, Omar, any questions have come up?
We have a question here, and they are asking, does non-surgical management with a cross-bracing protocol work for all ACL tear locations, whether it's proximal or mid?
I didn't catch the last part. The non-surgical management was what?
The cross-bracing protocol.
Okay, yeah. The cross brace protocol is the one I illustrated where they put them in a brace at 90 degrees for 4 weeks. And then each week they progressively increase the range of motion. And in your handouts, there's a couple of references there that you can search to get the details of the articles that are there. But the Canaan trial and the cross brace trial are different examples of approaching an ACL rupture as a non-surgical treatment. Again, as I said, they have followed those procedures with MRIs. And on MRIs, they look pretty good. But I just added that new slide that was published this week in Arthroscopy Journal that showed that, yes, on the MRI, it looks like the MRI shows healing of the ligament. But again, when they used a KT1000 or a KT2000, which is called a knee ligament arthrometer, you'd basically do a Lockman's with it, but it actually registers the numbers. So instead of just being a qualitative, well, how much do I think it is and what's the quality of my end feel, the KT actually puts a number on it. And what they have found on that recent study just published, 7 articles, over 300 patients, again, a systematic review, they found that yes, the MRIs look good, but when they did the KT testing, there was still a lot of laxity in those ligaments. So I made the comment then, we don't treat the MRI, but we treat the patient. So there's a patient that even though their MRI looks good, if they still have residual laxity, they go out to a cutting, twisting, pivoting sport, then that ligament may not be matured enough to stabilize them. So that's in, again, those references are in your handout for the cross brace procedure. So you can take a look at that and look up the original articles on that. Did that answer it?
I think yes. And nothing from the chat so far. So yeah.
Okay. Now, what I just talked about is really the traditional surgery. So I'm going to use that word. Because again, the innovative non-surgical approaches we discussed first. The second thing we talked about was the traditional, the bone patellar tendon bone, using the infrapatellar tendon, the STG, the semitendinosus gracilis, and then the third one now, which is the newer one, is the quad tendon. So they're the most commonly used surgical procedures throughout the world. Okay, so now what we're going to do is go into some of the newer innovative things that are being done. So we're now down to this point on the outline. There's one physician, Dr. Don Shelbourne from Indianapolis, and he has popularized the concept of using a contralateral bone tendon bone. Again, he's one of the very few in the country that does that routinely, because the concept is if you hurt your left knee, why do you want to harvest the graft from the good knee to now compromise the integrity of the good knee? But he has had some pretty good results with his long-term follow-ups. But as I said, that's not very commonly done by the majority of orthopedic surgeons in the United States or worldwide. So we're not going to spend a lot of time with that. What I now want to head into are these newer areas of the ALL, the LET, and the LEAP. And then we're not going to mention much about allografts. Again, that's obviously when it's retrieved from some type of a graft that you get from some type of a company that provides different grafts to be used for surgical procedures. So we're not going to talk about that because that is rarely used in high performance athletes because again, it's not as stable or as good. And the incorporation takes longer because sometimes we've had instances where people have actually rejected allografts. So we're going to now talk about the ALL, the LET, the LEAP, and then the primary repairs, which is also something new, interestingly, with the bear, and then actually using an internal brace. So let's move on. So here, several years ago, there was breaking news. A new ligament was found in the knee. Well, that's not really true. Dr. Segun actually identified the ALL ligament or the anterior lateral ligament back in the 1860s. And actually, whenever you see an X-ray or a radiograph of a patient who's had an ACL, again, many times you'll see right here on the lateral aspect of the tibial plateau, you'll see a little flake of bone that's off. That's referred to as Segun's fracture. And Dr. Segun was the first one to name the Segun's fracture due to an avulsion from the anterior lateral ligament that sort of went unknown for a century, and then it was popularized recently. But here you can see, again, the lateral aspect of the knee. Here's your lateral collateral ligament or your fibular collateral ligament. And then anterior to that, here's Gerdy's tubercle. So anterior to the fibula, posterior to Gerdy's tubercle, right at the lateral aspect of the tibial plateau is the anterior lateral ligament. Now, this is variable, and that's why I think it's been missed for a while. But nevertheless, some people, if there's a robust ALL, then some people have actually been using that for a ligament reconstruction. So again, here's an example. Again, we look at the lateral aspect of the knee. Here you can see the obviously femurs here, tibia here, and that's the insertion on the femur of the LCL or your lateral collateral ligament, and that goes down to the fibular head. Anterior to that, as you can see, is your anterior lateral ligament or the ALL. So in this specimen, it's pretty robust. So that could be potentially harvested and used for the ligament reconstruction. So that was one thing that has been recently done and only in the last 10 to 15 years. Again, here's another example from a pretty good cadaveric specimen. So here you see your lateral collateral or your fibular collateral ligament here. And then anterior to that, you see your ALL. So again, that's a very robust ALL. Not all of them are that big or that robust. So obviously, if it's smaller than that, you obviously can't be using it as a reconstruction structure. So combined, again, using other things, here's another study recently, interestingly, using the rectus femoris, the actual muscle, as an autograft technique. That's not done very often, but I just threw that in because that's something else that's in the literature. I read a bunch of journals, and it's always interesting to see what people are doing. But let's go back to the ALL. And now, if they're not using the ALL, if that's not robust enough, again, then they need to do something else to stabilize the rotation. Remember, the intra-articular ACL reconstruction stabilizes the sagittal plane because they're putting it more, instead of vertical, more horizontal. It also helps transverse plane rotation. Because remember, an ACL injury is a two-planar instability. But now what they're doing, again, in addition to the intra-articular procedure, they're now doing a lateral extra-articular tenodesis, or what they call, once again, different terms, and LAT, LET, different terms that are used. What's also interesting, back in the 70s and the 80s, before we did intra-articular procedures, interestingly, a lot of physicians only did the extra-articular procedure. So what I'm going to talk about now for the next couple slides actually were used exclusively for people that had ACL ruptures. We found, however, that the extra-articular procedures by themselves did not work. So consequently, that was abandoned. And then we went to the intra-articular procedure, which seemed to be better. Now comes full circle. So now not only are we doing the intra-articular ACLs, but also the extra-articular tenodesis. So that's the LET, or lateral, E, extra-articular, T, tenodesis. So, and there's different ones that are done. There's a Lemire technique. There's several variations, but essentially, if you look here, you can see what they essentially do is they take a strip of the iliotibial band and they basically pass it underneath of the lateral collateral ligament, and they bring it back and fix it back on itself, onto the Gerdy's tubercle area. So the point of the LET is to minimize, because if you stabilize the outside of the knee, it minimizes the internal rotation, which is that transverse plane rotation, which causes the ligament ACL injury. So that's the newer version that's being done only in the last 5 years. Quite honestly, in the trend in the United States, if they're a female athlete, because females we know have a higher incidence of ACLs, most of them have a little bit more laxity. So if they're a female athlete, if they're in a high level sport, if it's a pivoting, cutting, twisting sport, and they end up with an ACL injury, a lot of the physicians are now actually doing an intra-articular procedure, and they're backing it up with the LET, or the lateral procedure. So now you have good fixation internally, you have an extra backup externally, and that seems to be the trend. And I think that's occurring worldwide as well. And again, for somebody who has a revision, somebody had an ACL injury, they had an ACL reconstruction, they return back to sport, they re-injure. So then you have to use a different graft site. And then what they're going to do in almost all revision surgeries, they're doing an intra-articular ACL, and they're also doing a backup extra-articular tenodesis. So there's another example where you can see they basically have taken part of the iliotibial band, and they basically bring it around. They fixate it underneath the lateral collateral ligament and the underneath the popliteal fibular tendon, which is right there. And then they're going to basically bring it back and stabilize it. And that minimizes the internal rotation of the tibia. So again, the reason I'm mentioning this is important for physical therapists to understand relative to the rehabilitation implications. So again, how may you change? And sometimes you may not change it, but sometimes you may end up changing the rehab. Next, let's go to the primary repairs. The ACL rupture can occur at any spot. In the old days, if it tears in the middle, again, you don't have a good blood supply, it doesn't heal. Again, up here, if it avulses from the proximal tibia here, or the proximal femur, and it's an avulsion, then there's classifications for a Sherman type 1, which is close to its insertion. There's good blood supply, that'll heal. So that's what they're going to do, is they're going to do a primary repair. So again, we've tried repairing tears in the mid-substance. That doesn't work. Because again, even though they put the sutures through the torn parts, the synovial fluid keeps bathing that area, and you don't have a blood supply, doesn't heal. So What they've now gone to is using an ACL primary repair. So there you see the ACL is torn in the mid-substance. What they're now going to do is use a scaphoid sponge. The sponge is going to be placed over where they do the sutures in the ligament. Then they put the sponge around that area to keep the blood supply in. And they may actually have the sponges saturated with additional blood. Some will even use a PRP and different things to try to use orthobiologics to facilitate the healing. And this is now FDA approved in the United States. So again, there's your ACL tear. Even though they do sutures through it, again, if that's all they do, then the synovial fluid just prevents the blood supply from healing it. So now they use this sponge or this bioactive scaffolding it. They put it around that area to keep the blood supply in to allow the healing to occur. So there's an example where the ligament is, and here's the sponge that basically goes over top of the ligament. And that sponge, again, is saturated with blood, and maybe PRP is an orthobiologic to enhance healing properties. And there's the example where you have the healing from the suturing, but then on top of that, again, get me out of the way, here you can see the sponge. So that's going to be basically preventing the blood supply from being washed away. And that's what it would look like schematically. So again, there it's proprietary. So that's the concept of right there. And that's called the BEAR procedure. So again, the BEAR is the acronym for Bridge Enhanced ACL Repair. So there's the ends of the ACL torn. Then they do the sutures. Then they bring the sponge, if you will, over top of that. And then that in turn allows the implant to absorb the bleeding and the healing process. And usually it heals within several weeks. There have been pretty good follow-up. So again, I've actually gone through the certification process to become a BEAR rehabilitation physical therapist because they do change the guidelines. It's much slower than most of our most of our reconstructions, because again, you got to allow time for the healing process to occur. So again, it's slower, more delayed. Again, selective patients for this, rarely used on really high performance professional athletes or at the high performance Division I athletes. Last thing is just adding, I think most of you are probably familiar with the Tommy John procedure in the elbow. One of the big innovations in that in the last 5 years has been using an internal brace, which is basically an extra cord that's put into the UCL ligament to provide stability. Now that internal brace is being used for everything. So here's an example. They do an ACL primary repair where you can see all the sutures, but now they're using the internal brace to reinforce and stabilize the repair. So that's one of the newest innovations that's being done. I have not seen a lot of those yet. I've had a recent volleyball player wiped out her ACL, both medial and lateral meniscal tears. So she had a medial lateral meniscus repair and ACL quad tendon repair with the internal brace. Doing great. She's going to be back to volleyball next season. So again, there's just another example where you see the traditional fixation of the ligament, but then the internal brace is to reinforce it. So again, it helps stress shield the forces to the healing ligament so it doesn't stretch out in the healing stages. And it helps, again, stress shield the healing ligament. So it does make sense. It does make sense. It's been effective elsewhere. Here are some of the recent literature that shows the effectiveness of doing the tightrope or the internal brace. So again, in contrast to using the metal implants or screws or something like that, staples, buttons, whatever, there's the example with the tightrope or the internal brace where they use adjustable loop fixation. You can't really see much on the radiographs. And that way you don't have any skin irritation as well. All right, so that went through we'll get into rehab shortly. But again, I think we need to understand as physical therapists, we need to understand what the physicians are doing. And again, if you ever have the opportunity to spend time, if you work closely with one of the physicians, try to go to surgery with them so you can actually appreciate what they're doing surgically and understand some of the nuances about if they're doing just an intra-articular, if they're doing just an extra-articular, which is not done very often, but more commonly now, as I said, in high performance athletes, they're now oftentimes doing an intra-articular with an extra-articular backup, the LET or the LEAP. And again, in some cases, you may hold it longer because they now have that lateral incision, and that takes a little bit longer to heal. Plus, they're going to complain of more pain out there during the rehab. So, understanding those surgeries to me is really the most important thing relative to being able to do a good job in rehabilitation with patients. Questions? We have a lot to cover, so if there aren't any questions, I'll keep moving on because after certain periods, then I'll stop and ask if there are any questions. So how are we doing, Omar? Any questions in the Q&A?
Well, we have a question here, and he's asking that nowadays they are using peroneal tendon as a graft reconstruction in Turkey. What do you think of it?
Good question. Thank you for the question. The quad tendon, is that correct? Is that what I'm hearing? Omar, was it the quad tendon?
The peroneal tendon.
I'm sorry, which one?
Peroneal.
I'm sorry, I don't know.
Peroneal tendon. That's the question, right?
I still don't understand which anatomy. Say it again clearly.
Um, البيرونيال tendon. The peroneal tendon.
The Achilles. Is
Nowadays,
that
they are using peroneal tendon as a graft reconstruction in Turkey.
am I right? The Achilles tendon?
Peroneal.
I'm,
Peroneal tendon.
I'm sorry, I'm not understanding the question. I'm sorry.
It's
I,
a
I
muscle lateral to the ankle. Peroneal
for the
muscle. I think
anterior tib tendon?
lateral ankle muscle crossing the lateral ankle called the peroneal muscles. So he's asking that they are using this tendon as a graft reconstruction in Turkey.
I'm still not understanding which tendon.
Uh, I think it's called peroneal tendon. Peroneal tendon.
Lemire tendon?
Peroneal.
EMO.
Peroneal, Professor Pranay.
Peroneal, yes.
I'm sorry.
Pranay,
I'm sorry.
peroneal tendon.
He means the fibularis tendon.
Oh, fibularis. Is that correct?
Yeah.
Yes.
Oh, okay. I'm sorry. I just didn't. Again, it's another option. I don't think it's one of the best options because if you harvest the fibularis tendon, once again, you're going to compromise the integrity down at the ankle. So again, it's everything in the body has been used. Anterior tib tendon has been used in the United States. I don't think I've ever heard of anybody using the fibularis tendon in the United States. Some have used the posterior tib tendon. But again, when we start taking those tendons again from the ankle, that's going to lead to compromise of the ankle stability as well. Because again, the ankle doesn't have a lot of muscle or tendon around there for stability. And you start taking a tendon away from there, that's going to lead to further instability in the ankle area. So in the United States, at least, doing anything around the ankle, any of the ankle tendons, the Achilles, the fibularis, the anterior tib, the posterior tib, we do not use many of those at all as part of the graft sites. As I said, I went through the traditional ones and I went through some of the newer procedures, but some of those tendons are not used regularly in the United States. I'm not saying that's right or wrong. I'm just saying it's not common practice in the US. So, and I've never seen any of those as a clinician, and I've been doing this for a long time. So, okay, any other questions right now? Because we got to rehab this soon here.
Nothing from the chat so far.
Okay, let's move on. All right, first thing, talk about rehab, prehabilitation. So let's address that first. Before the patient even goes into surgery, this is probably one of the most important things that we have to do. You send a cruddy knee into surgery, you're going to get a cruddy knee out of surgery. So ACL injury pre-op phase, obviously try to decrease the pain, decrease the swelling and the effusion, increase the range of motion back so it's symmetrical to the other side if possible, get muscle activation to minimize the AMI or the arthrogenic muscle inhibition, and increase the strength as much as possible. The better the knee going into surgery, the better the knee coming out of surgery. And there is some evidence to support that. So again, so what do we want to look at? Ideally, just using some examples, we want to have pain less than a 3 with activity. Passive knee extension should be at least 0. But most people, the American Academy of Orthopedic Surgeons, range of motion at the knee is 10-0-135, meaning the majority of people do have some hyperextension or recurvatum. So the whole idea is if you can, both pre-op and certainly post-op, you want to try to get the knee back to the same position as they were in the beginning. So if they have 10 degrees of hyperextension prehab, then that's what we want to get post-surgery. So that's important. But again, if we can just get them to 0 to get them into surgery, because you don't want to prolong that too long, because the longer they don't do surgery, many times you get concomitant injuries, meniscal tears, cartilage problems, etc. And then passive knee flexion. So at least 0 to 125. Normal is 10-0-135. 10 degrees of hyperextension, 0's neutral, straight line, 135 is normal flexion. No swelling or effusion ideally, because that creates the AMI. Strength should ideally, if you can do it, however you measure it, we'll talk about that as we go along. Again, should be about 90% limb symmetry index. Again, many times jumping is okay because it's both knees. So if they're still apprehensive, have kinesiophobia or whatever, they're going to stress shield the involved knee and land with more weight on the involved side. Rarely, again, will you do a hop test. Some people do, again, but I find most people prehab have apprehension or, again, have a lot of kinesiophobia, and they don't want to hop on and land on that one leg. Pushing off is okay. That's a concentric controlled motion. When you're in the air and you have to land on that one leg, that's scary for the patient. So a lot of patients don't like to do a hop test. Again, if you do those, you look at limb symmetry. So that's your LSI, limb symmetry index. So a jump test, they should be about 90 to 100% of their height. Again, when you do a jump with both legs, you don't have anything to compare it against. So we compare it, we do allometric scaling, meaning we scale their distance to their height. Should be about 90 to 100% for males, females 10% less to 80 to 90. Hop test, again, you want symmetry between right and left or dominant, non-dominant. But then we also do allometric scaling, and we like to have it to their height. About 80 to 90% is what our norms are. But again, prehab, many patients, because of apprehension and weaknesses, they don't achieve that. So I would try a jump test, but I rarely will do a hop test prehab. All right, so with that, now, what we do is this is just the model that we use. We start with our pain control. We do a bunch of things. Mobility, get the motion back. Stability, where we start all the exercises. Capacity, start including the endurance, the total body, cardio, the whole thing. Then progressing into skilled activities and then return back into full activity. So that's our model of therapeutic progressions that we would follow. So with that, what do we do in 2026? So first thing, some physicians will brace, some will not. Again, that's a physician's call. Some will have them braced with a leg fully locked at 0. until they get good quad control, et cetera, and then start opening the brace. Some don't. That's the physician's call. Now, the next consideration is, what about the healing? This is an interesting concept. So again, we have to be aware of the soft tissue healing concepts. And as I said, with that Conan trial, they showed healing with MRIs, serial MRIs. But what's really interesting, if we look at some of the healing process, this is a study that was done at the University of Pittsburgh, and Jay Ergang, who's the director, allowed me to use these slides. So let's start in the upper left-hand corner here. The normal ACL, there's your patella, there's the tibial tuberosity. Your normal quad tendon should be very dark, meaning there's a lot of blood supply, good quality tendon. They harvest a bone tendon bone. Now they drill through the tibia up through the femur and they put the new graft in. So that's time 0. You can see it's nice and black, dark, looks good, good vascularity, good potential. Then at 1 month, they repeat an MRI. You can see still looks pretty decent, little questionable there. And now, interestingly, at the 6-month mark, look at that tendon. Doesn't look very good. So this is the patient that I think is the problem, that they may pass all their tests, the range of motion, the strength, functional tests, etc. But this is a patient that is functionally ready, but from a soft tissue healing standpoint is not ready. So this would be a slow healer as an example. So what does that mean? What happens here? So when we look at the healing, when they think about that now, they're taking a tendon, whether it's quad tendon, fibularis, whatever, quad tendon, Achilles tendon, infrapatellar tendon, STG. They're taking a tendon and now they're putting it inside the knee joint. That tendon's not used to being bathed in synovial fluid all the time, and it's a tendon. Now we're asking it to act like a ligament. Think about that. It's amazing how the body matures and helps with that. But here's what has to happen. The biology and Mother Nature, it has to go, first thing is neoangiogenesis. So we're taking a foreign substance and putting it inside the knee. The knee's first reaction is, wait a minute, that doesn't belong in here. So it has to accept it, and then it has to let the little genicular arterial blood capillaries grow into that area to create new angiogenesis to become a viable tissue. Then it has to go through the maturation phase, and then that tendon now needs to start acting like a ligament, acting as ligamentization. So how does that occur? How long does it take? Interestingly, here's a reference. You can go back and read it, but I'm just going to summarize some of the findings with it. So interestingly, what they did is they looked at, the initial one was with animal models, and they looked at how long the healing takes place. So the early healing is here in the dark blue, then the medium blue is remodeling, and the maturation is the light blue. So these 3 studies have all looked at healing in animals. So if we look at the early healing, as you can see, all of those show 6 months. Remodeling, all of those are pretty much by 12 months. And then the maturation after that. Interestingly, if we look at how long it takes for human models, so these were people that ended up getting killed in accidents or something. They harvested the knees, and then they did biological, histological, mechanical, biomechanical studies. So if we now look at the human model, again, look at the early healing. Remember, the animal model was about 6 months. Look at this, closer to 12 months of just the basic early healing. And then the remodeling, 18 to 24 months. And then only after 18 to 24 months do you start getting maturation. That's why some people say that after an ACL reconstruction, it takes a couple of years for that ligament to really go through the maturation and healing process to be a good, sturdy ligament. So back to our case, looking at this patient, If we now perform that MRI at 1 year, look at the difference from 6 months to 1 year. The darker the color, the better. So again, if we compare it at 1 year, again, the darker the color, the more vascularity, the more the maturation phase, the better the quality of the tissue. And compare it back to time 0, it looks pretty good. But that takes a while. And again, where in here is the sweet spot? Well, the literature has said for a while that it should be about 9 months. Here's an interesting article recently. Is 9 months really the sweet spot for male athletes to return to sport after anterior cruciate ligaments reconstructions? So completing rehab and meeting objective criteria significantly increased the odds for male athletes to return to pivoting sports. However, time to return to sport did not impact the risk for a new ACL injury if the athletes met the objective criteria. So this was just published a couple of years ago. So there's still controversy, but to me, it makes sense. We have to respect soft tissue healing. We have to look at the patient's PROs, their patient-reported outcomes. Do they have pain? Do they have kinesiophobia? And we have to certainly look at the whole concept of their objective testing. What's their strength? What's their functional testing, et cetera. Here's just a graph that shows the healing of different biological tissues, tendons, muscles, ligaments. Here's the ligament graph. And as you can see, some say the ligament graph starts healing at about 2 months, but could take upwards of 2 years. So that's just an example. So once again, we need to respect Mother Nature is the take-home message. Questions on that? As I said, I think that's a really important concept that we as physical therapists really need to understand. Sometimes, even though we like to pride ourselves on being aggressive therapists and being cutting-edge therapists, getting our patients back quickly, getting our patients back faster than the clinic down the street, I think we really need to be very respectful of soft tissue healing. So any questions with that? Again, there's a couple of references in there that you can refer to and see what the latest state of the art with that concept is about. Omar, anything with that? Can we
There are
just
no
keep moving
questions
on?
related to the previous section. Yes, I can move on.
All right, let's move on. After the ACL reconstruction, again, I think this is an interesting concept published in British Journal of Sports Medicine. Recent evidence indicates successful return to sport hinges less on the surgical intervention, even though some of these advances have been made, and more on criterion-based rehab progressions. So that's what we're now going to turn to. So starting with phase 1. Phase 1, these are some of the considerations that we need to address. Patient has that serious knee injury. We have to look at decreasing pain, decreasing effusion, increasing range of motion, respecting healing constraints, as we just discussed, getting muscle activation, overcoming AMI, increasing proprioception, increasing total body strength and total leg strength. So these are the concepts we're now going to go through, each one kind of briefly. So again, some outcome measures that we need to look at each of these phases. We need to get that passive knee extension to a minimum of 0. As I said, it really should be similar to the other side. Sometimes in phase 1, though, with the pain and with the effusion and the apprehension, et cetera, we may not be able to get all that, but we want to get at least 0 at the minimum. Then we try to get hyperextension to whatever the other side is. Up to 10 degrees. If somebody has more than 10 degrees, they have excessive hyperextension, or they have a high Beighton score, they're hypermobile, Ehlers-Danlos syndrome, then we do not push past about 10 degrees. Passive knee flexion at least 125, decrease the swelling and effusion, activate that quads, and hopefully when they do a straight leg raise, as we all know, we want to lessen a 5-degree quad lag. That's just a number to give you an idea. If there's more than that, they're not really being able to control the quadriceps. So what do? So let's go back to the basics. Again, I'm going to go through these fairly quickly because these are some of the basic things. But again, I know when we look at social media, we see a lot of fancy things going on. My philosophy is always back to the basics. Think of an analogy. If you build a house, you don't put the siding and the roof on, but you start with a good solid foundation. We need to do the same thing in rehab. Don't skip all the basics to get to all the fancy functional stuff that you see on social media. Make sure you do your basics and do it well. Frankly, if you do the basics well with most patients, you're going to get most patients better. So these are some of the things we're going to address. Obviously, pain. The science of pain, obviously, it's unique to every individual. How do you relieve it? Again, when we start looking at the interactions of pain and where it comes from, that it's not only peripheral pain, but we now know it's centrally mediated as well. So there's a link between inflammation and pain. So when we get injured, we get some inflammation in the joint just from the nature of the injury. That changes the chemistry inside the joint. That creates different stimuli that transmit electrical signals through the nervous system. So once more, it's not just peripheral pain, but it's centrally mediated pain as well. And that's going to change some of the changes. And obviously, the brain is what interprets the pain stuff. So inflammation is a normal response, but again, it's not in and of itself pathological. We have to address that. So what can we do? All right. Here's, I think, just a cute slide. Everybody wants the easy way out, taking pills and getting something done versus lifestyle changes. But nevertheless, we can use medication. Again, that's under the purview of the physician, what medication they think is the most appropriate. This comes under our turf. So again, things that we can use, different exercises, different modalities, ultrasound, TENS. We can do different types of hands-on techniques, massage, mobilizations, dry needling perhaps, heat or ice, depending on the stage the patient's in, and then pain neuroscience. And again, as we all know from Therapeutic Alliance, patients value several things. The most important thing the patient values is communication. So again, communicating and educating the patient about pain science and what's going on is one of the most critical things. The second thing patients value the most is hands-on. So again, education and communication is the number one priority. Again, using different modalities, whatever you have available, whatever works in your hands, whatever you have available in your clinic, whatever the physicians and you feel are appropriate for the protocol. That's just a laundry list of different things that are used commonly in treating patients in the early stages of ACL rehab. Again, one of the biggest concerns, as we've discussed right from the beginning, the normal knee. Look at the size of the suprapatellar capsule. It goes almost 2 hands distances up the thigh. It's huge. Again, the knee joint is the largest synovial joint in the body. So again, we have to address that. I just thought that was an interesting slide. Look at this. This guy actually had a fracture and he kept going during the Tour de France. Look at what happened after he bicycled 60 kilometers. Look at the size of that leg. I mean, amazing to be able to just persevere doing that. But nevertheless, wow, that's a huge, huge effusion. All right. So these are the things that, again, we're addressing. Back to address that effusion. Now we got rid of the pain. Now we're going to address the effusion. So again, these are some of the reasons why we have to decrease effusion. Effusion causes pain. It minimizes range of motion, causes degradation to the synovium, degradation to the articular surfaces, and it creates arthrogenic muscle inhibition. So there's your flexion contracture right there. That is devastating. We need to get rid of the effusion and get the motion back. Furthermore, again, the effusion in there creates a reactive synovitis, and that reactive synovitis creates degradation changes to the synovial lining, and that in turn creates that inflammatory response and the degradation and pain, swelling in the knee. The degradation changes the articular surfaces. So that's the reason we have to get rid of the swelling and the effusions. And now when we look at AMI, again, this is a recent article looking at how do we address AMI in the knee. And again, different ways. The two most common, you see them right here. doing exercises, appropriate exercises, and cryotherapy. So again, as we know, AMI or arthrogenic muscle inhibition. Arthrogenic's joint, genic is creation. So the swelling in the knee creates the inhibition response. So again, that in turn creates the muscle atrophy. So you don't have the normal knee and you start getting the atrophic changes that result in the weakness in the knee. So how do you address the muscle inhibition? Again, one more time, a laundry list of different things you can use. Obviously, most important is get activation of the quads. So basic, plain old quad sets. And then you can do four-way hip things, again, distal, but get the quads going. So active quad sets. You can use biofeedback to enhance that. You can use E-stim to facilitate the activation of the quads. You can use BFR to enhance that. Using contralateral cross-education, concentrically and eccentrically. So if it's my left knee, I will often work the right knee real aggressively to get that contralateral cross-education overflow. Lasers, using internal or external focus of attention, motor imagery, VR, transcutaneous stimulation. All of these things have been used to try to, again, address the muscle inhibition. And again, it goes back to the inhibition that's being created in the brain. So again, we have all that tissue trauma that occurs. We get the inflammatory response from the effusion. We get a muscle spasm that inhibits the activation. You don't have normal movement that leads to adhesions. Altered neuromuscular control creates weaknesses, resulting in muscle imbalances. So that's the vicious cycle. And here again is just an example of what that AMI or the arthrogenic muscle inhibition creates as it goes through that process. So again, the different things that we need to address is that neuroplasticity. One of the main things we can do there is exercises, and then get the spinal reflex pathways. You can do things like the NMES, TENS, vibrations, perturbation type of training. And then again, with that Sonray Cotter article, cryotherapy is also very helpful. It minimizes some of the joint damage and creates the inhibition of some of those spastic responses. So that arthrogenic muscle reflex inhibition is critical to address in the early stages. Lots and lots and lots of studies have shown that. Then moving on again, getting the motion. So we got rid of the pain, we got rid of the effusion, and we're getting the AMI, getting the muscle activation. We need to get the motion. So again, just prone hangs are very effective to make sure we don't get swelling in the knee, and we start to stretch out the posterior capsule and the posterior hamstrings, doing seated weighted movements, using a dropout cast if it's really severe, patellar mobilizations, active terminal knee extensions. So we get the passive motion, then we have to be able to get controlled motion of the knee, doing TKEs or terminal knee extensions. So again, that's one of the best ways in early closed kinetic chain exercises to get active control of terminal extension of the knee. Now, if something doesn't go well in physical therapy, we get blamed for a lot of things. I don't think that's always the case. This is, in my opinion, the physical therapist's fault. That if we don't get that motion back in the knee, for whatever reason, the patient can end up with what's called a cyclops lesion. A cyclops lesion is because of all the work they've done inside the knee. It causes a lot of inflammation. The infrapatellar fat pads are the most highly innervated and one of the most vascular structures in the knee. Consequently, it creates a huge inflammatory response. Consequently, ends up creating all this scar tissue in the notch of the knee. The scar tissue in the notch of the knee prohibits regaining full extension. So consequently, we can't extend the knee because all that scar tissue is there. So we have to regain full extension as early and quickly as possible. If we don't get that, that's the physical therapist's fault in most cases, because we weren't aggressive enough to get that to prevent a cyclops lesion from developing. If you get your full motion back, then you don't have room for that scar tissue to develop. So that's a critical concept early in rehab. And then obviously working on flexion, you could do that a variety of ways. Here's just doing some wall slides, etc. So getting motion is the next thing that we have to do. Questions so far? Early stages of rehab.
We have a question here, and he says, "What is the single most overlooked factor that leads to ACL re-injury after return to sport?"
If you would hold that question for return to sport, we'll get to that later, if that's
Yes.
okay.
That's okay.
So again, we'll talk about some things. I will address that because I want to now go start getting toward the intermediate phases to make sure we have time. And I will stay as long as necessary to answer every question there is. But when we start talking about return to sport, there's specific things we do, and I'd like to hold that if we can. So let's stay right where we are right now, where we're doing muscle activation. So we talked about getting rid of the pain, getting rid of the swelling, getting rid of the effusions so we can get rid of the AMI, getting full motion, now on the muscle activation. So once again, one of the things that I would really recommend is think about using different angles of the knee for multiple angle isometrics. So typically, we usually work patients in this position, okay? But what happens if you put them in different positions, you change the length tension ratio of the quadriceps and the hamstrings. We've actually published on that in the past. So what I'm saying is when you're doing multiple angle isometrics at 0, 45, 50, whatever you're doing, again, not only change the angle of the knee, but change the angle of the hip. Because many of as we know, many of the muscles, hams and rectus femoris, are biarticular. So you could actually change the forces that are created by changing the position from seated, semi-sitting to prone, or sorry, supine, and that allows you to do a good job in all different areas. So early on for muscle activation, we do submaximal to maximal multiple angle isometrics. Interestingly, when you do an isometric contraction at whatever that angle is, let's just say that angle's at 30 degrees. With isometrics, you get a 10-degree overflow on each side. So I'm not only strengthening that patient's knee at 30 degrees, but I'm actually strengthening it from 20 down to 40. So that's the neat thing. There's a physiologic overflow strengthening when you use multiple angle isometrics. So that's how we get that activation early. We've already talked about you can use muscle stim. That facilitates the contraction. Again, there's different recommendations, again, in the literature, where to put the pads, what intensities you use, using biofeedback. Here's an example of using biofeedback with one of my patients. But if you notice here on her leg, she also has BFR. Look at the discoloration of the legs. You can see this is restricting the blood flow, so you're getting that response. So she should get the activation in the green. So now she goes down, no activation. Now contracts the muscle. Now you can see she gets it up into the green, which shows she's getting a good muscle activation. So there I'm using biofeedback along with BFR to get that muscle activation right here. So
look at the green.
So again, one more time, no muscle activation. Now she tightens right at the beginning, holds it, holds it, holds it. And you can see the discoloration that's occurring from the BFR. So I think BFR is one of the best things because the patient can see how hard they're working and they can see the changes in the muscle activation. Now notice, once again, when she relaxes up at the top, you'll see that'll go to white. So green right away, hold it. Now she's not holding it very well right there. Did you see how it was fluctuating?
Good.
So as I said, I use a ton of biofeedback. I think it's one of the best things to get muscle activation and prevent the AMI. Again, we can use that in a weight-bearing position. So here she is doing kind of almost a pistol squat. Notice she's looking, watch over here. There's your biofeedback. You can see when it goes green, optimal activation of the quads. She also has BFR on, and we're using dyad training. She's able to look in the mirror to get feedback. And I think that's another very, very important concept early on to make sure they're not compensating when they're doing an exercise. So using Miro as a feedback is called dyad training. So once again, the biofeedback for the intensity, the BFR to enhance the recruitment of the fast twitch fibers, and the dyad training to do the exercises correctly. So once again, BFR, we're all familiar with that, and there's plenty of research. There's 1,000+ articles on BFR now. So we can use BFR to enhance the performance. So there's an example. There's different systems that can be used. So again, here using BFR in just a supine position for muscle activation, almost as you saw using the biofeedback and BFR. You can use BFR by itself. And again, a supine position, that's not real exciting. Now we can use BFR, as you'll see here, with a patient doing active concentric, eccentric exercises on a leg press. Now doing BFR in an open kinetic chain position.
3 pounds.
So all the way up, hold, all the way up, hold. Now doing BFR in a closed kinetic chain position. Down to hold. So again, BFR is a great adjunct early in rehab. Next is the concept of perturbation training or proprioception kinesthesia. You can do it in a closed chain position. So there's an entire book that deals with this concept. So again, here's a study recently that looked at some of these concepts, but look at this conclusion. Patients who've had an ACL rupture, proprioceptive deficits improved with their ligament reconstruction. Knee outcome had a better correlation with proprioception than with ligament laxity. Proprioception may be a superior objective measure than just using ligament laxity and quantifying functional knee deficits and preparing patients following an ACL rupture and surgery. So let's start with, what do we do with that? So there's a lot of information on the effects of proprioception and what's going on when you injure an ACL. We know there's a lot of effects to the brain. So again, the first question is, how do we test it? Bunch of ways you can do it: balance testing, open kinetic chain angular joint replication, closed chain angular joint replication, which you'll see on the next several slides, and then others. So the first thing is you can use a balance tester. So that device allows to measure how much their center of pressure varies from anterior, posterior, medial, lateral, etc. We can do open kinetic chain proprioceptive testing. So in other words, the patient is seated. We move their leg to a certain angle in the range of motion. Their eyes are closed, so they can't see. So we move their leg to a certain angle, such as that. We bring their leg back to the starting position. Patient reproduce that angle. So it's active angular replication. They then move their leg up to that position. So we then measure the difference in degrees. So as you can see, they overcompensated a little bit. We do that at multiple angles, usually 90, 60, 30. And that allows us to get the proprioception at different angles within the knee in an open kinetic chain position where they can't, say, do closed chain or weight bearing to begin with. Here's an article, again, retest reliability of doing the active joint position testing in patients that have ACLs. So again, you can do goniometry, you can use a tensiometer, whatever. You can also do it weight bearing. So having the patient standing, eyes are closed, ask the patient to do a squat. As they squat down, you stop them. And again, we would do it about 90, 60, 30. And again, their first position, they were at the black line. That was we measured it with a goniometer. Patient goes back to full standing. Patient, do your squat and replicate that angle. Then they go down. We remeasure the next angle. And again, we measure the difference in degrees. We look to see how closely they can replicate it. Again, there's not a lot of researchers. That one previous article, our literature has showed about a 5-degree variation is within normal limits. But again, I haven't done a lot of research on that. I've actually done it in the shoulder, and we have the numbers and published that 30 years ago. We haven't done it in the knee yet. Or here's another example of using a stabilometer. This device, you can notice the force plate varies. You can notice the perturbations. It goes in random order of medial, lateral, anterior, posterior, clockwise, counterclockwise. So that's another way to measure the dynamic balance. And you get a number on the screen on the stabilometer. So there are different ways to measure proprioception. Critically important to measure that. We know it's a problem. All right. We can also do a dynamic Y balance test, a star excursion test, whatever term you want to use. And again, we do that routinely in the clinic. So they basically go in an anterior, a lateral, and a posterior medial direction. We just simply look at limb symmetry. So when they move forward, there's numbers on here. They get to whatever the number is. Let's just say it's 20. Then when they switch legs, then they would move forward with the other leg, and let's say they get to 18. Then we would do a limb symmetry between the two. And that allows you to look at a star excursion or a Y balance test to get dynamic testing in different directions. Now, furthermore, it's been my clinical observation when patients start to do different exercises following an ACL, that when we start them in, say, a squatting movement, that they oftentimes will not bear weight equally and they unload the involved side. So consequently, we actually did a study. We had almost 100 ACLs. So we looked at the loading response following ACLs, following a parallel squat, and we used a Smith squat rack. This was published a while ago, 25 years ago, but we looked at their weight bearing. So we had weight bearing recorders in their shoes and their feet, and we looked at how much loading they were putting on each leg. What we found, interestingly, is the more they flexed down into the squat, the more they unloaded the involved side. So they put more weight bearing on the good side. The more, and we basically had them go 30, 60, 90. We also just had them do a squat with their body weight. Then we took 25% of their body weight and then 50% of their body weight. What we found is the more external weight, we had them in a Smith squat rack, so it was safe. The more weight we put on them, again, the further they squatted, the more they unloaded the involved side, the post-ACL injured side. Interestingly, we tested them serially at 3 months, 6 months, and then at a year. And what was really interesting is they unweighted to 6 months, just simply putting symmetrical weight on a squat. They didn't do it up to 6 months. And many times, some of us are returning people back into sports at 6 months. They can't even equally weight bear. All right. At 12 months, they normalized. They were putting symmetrical weight bearing on each leg. We don't know between 6 and 12 months when that normalized because we did not measure it. So, but what was even more interesting is we asked the patients, are you putting equal weight on both legs? Every patient said, yes, as I'm squatting down, I am keeping equal weight on both legs. So that's an example of the lack of proprioception they still had at that 6-month mark, because they didn't even realize they were unloading the involved limb. So one of the ways to do that, as you can see, somebody here is compensating where they're, again, putting more weight on the right side as she's tilting over. So the easiest thing to do that when you see a patient do that, just put something under their foot that forces them to weight bear more on the involved leg. So that's a simple, quick way. When you notice somebody, however their qualitative assessment, they're tilting, leaning, whatever, just put something under that leg, and that forces them to put more weight on the involved extremity, so they have to do more of the weight bearing there. questions on the concepts of proprioception or kinesthesia testing or rehabilitation? As I said, to me, I think that's an often overlooked area in almost all areas of the body, frankly. I don't think most physical therapists routinely do proprioceptive balance testing on the knee, and I think it's even less commonly done in the shoulder. But are there any questions with what I just presented there? There's a few references that are in your handout. You can look those references up to find more details. I'm just trying to give you a summary of what we've done, some things we've published, and that way you can follow up with the references that are in your handout for more details. But Omar, any questions right now?
There are no questions related to the previous section.
Okay, let's keep moving. A lot of stuff to cover. All right, moving on. Next thing we want to do is focus on total body strengthening or total body training. And that's the concept of what we refer to as regional interdependency. Even though we're dealing with the knee right now, we want to look proximal and distal. So we need to do everything with that. And that's the whole concept of what we call TLS, total leg strength. Look at that example. That's your typical ACL mechanism of injury. We see the dynamic valgus, and we see that rotational component. So again, if you look at that, not only do the quads and hams stabilize here, but what about the proximal hip muscles stabilizing that internal rotation of the femur? And then what about that ankle muscle group stabilizing that ankle as best it can? So again, we want to look at everything. So starting from the core, we start, and again, I'm just going to go through some examples quickly. Everybody has different approaches they use. These are some examples. So starting with the core and then working our way down. And again, looking at the core stability, and you can do it in many different ways on the floor, stable surfaces, unstable surfaces, quadruped, tripod, bipedal. Again, doing different types of things, just working isolating hip extension like that, an often overlooked area. Doing posterior chain progressions, doing it again on different variations of unstable surfaces to doing dynamics. And at the very end, you'll see some other examples of this. Again, here's one of my favorite, we call it tantrums. So working on knee flexion. So having the patient go as fast and as hard as they can. And that way you can see the hamstrings are getting fast, ballistic, dynamic movements, and they're going all the way down to the table. And we can move that ball up further or further down or further up to increase the range of motion and make the muscles work in a lengthened position. So again, you can keep it way far down so it's short arcs at the beginning, or we can move it up further and further, put it almost underneath over their lumbar spine, so they have to do full range of motion. So again, that's how you can do short arc progressive training for short arcs to full range. And again, the other thing that's the beauty of this is people don't get injured with a hamstring or other injuries at slow speeds. Everything is really occurring at really fast angular velocities. So that's why training like this is really important. So now heading on to phase 2. So that's a transition, kind of giving those more ballistic movements to phase 2. But obviously at this point, hopefully with your ACLs, gait is normalized. You improve the proprioception through a lot of the things we talked about, testing them with either single balance or doing the Y balance or whatever, getting muscle strength return, increasing single leg strength, the quads, hams, improving double leg squatting with no compensatory movements, as I just showed you from the study we did, and improving single leg squats with no compensatory movements. So once again, these are some outcomes. So these are just examples of things that we want to look at. So again, passive knee extension compared to the other side, knee flexion at least 125, 135 is normal. No effusion, balance testing, eyes open, standing on single leg balance. They should be able to balance 43 seconds. Eyes closed, about 9 to 10 seconds. Functional, because there you can see when we injure the ACL, we also rupture a lot of the mechanoreceptors in the knee. Consequently, we become more visually dependent because we don't have the mechanoreceptors in the ACL ligament anymore. So we become visually dependent. There's an example. So that's why you'll see later on some of the rehab types of things we do with patients. Functional alignment, they don't have a lot of compensatory movements. Single leg bridges, again, that they should be able to do 85% limb symmetry up to 20 reps. Calf raises, side planks. These are just some numbers in the literature that are used. Again, you establish your own numbers based on your own clientele, patients, etc. But at least it gives you objective numbers to use. So obviously, qualitatively looking at movement alterations and make sure they're not compensating. Movement biomechanics, again, we know from a lot of studies over the last 2 decades that movement alterations may persist up to 2 years. As we said, a lot of things really don't normalize with ACLs for a couple of years. ACL injuries result in altered movement patterns. So that's why measuring things, but also qualitatively looking at things to make sure the patient's not having a lot of compensatory movements. And again, by those altered movements, how do we need to change our traditional rehab? Looking at, again, not only the objective metrics, but also looking at some of the qualitative assessments. So by working, again, a lot of people don't test above and below the knee. My question is test, don't guess. And if we do something like a squat, a lot of people say, oh, a squat tests everything in the lower extremity. I agree. We know about everything in the lower extremity. But if they do a squat and we notice some movement impairments, or if they're weaker than they should be based on norms or their pretest data, or compared to others in their normative data or sport or position in the sport, if they don't have the same metrics, even though they did a squat pretty well, where is the weakness in the kinetic chain? So that's why we believe in testing each link in the kinetic chain. So we do quickly handheld dynamometry around the hip. If you have isokinetics, quads, hams, you can do a handheld dynamometry real quickly distally. But again, even if we don't test, because most clinicians don't, frankly, then we still work each link in the kinetic chain. Again, exercises for treatment of the knee is treating everything. So again, if we have not tested something, we don't know whether or not there's a deficit. If there is weakness in one link in the kinetic chain, it can cause all these problems. Abnormal motor synergy patterns, asynchronous recruitment of the muscles. Muscles proximal and distal compensate for a weak link in the kinetic chain because of the concept of regional interdependency. There may also be a concomitant injury distal to the major injury we're dealing with. If one performs functional movement patterns, there's not enough of a stimulus to individually identify weak links. And we may not be able to identify where the problems are. And then we're certainly not going to identify where it is in order to be able to correct it in our rehab. So back to that analogy that I used before. When we build a house, we want to start with a solid foundation. Then we put the siding and the roof on. We do that with everything in the body. Ankle injuries, hip, knee, shoulders, elbows, wrist and hand, spine. So we basically do what we call our bottom 10 or 12 exercises. So hip, and I'm just going to run through these very quickly. Everybody's familiar, but you'll see a bunch of variations that you can use. I'm not going to point out every exercise, but you can just scan through the different examples of how you can strengthen the muscles. So sagittal plane exercises, hip flexions. Sagittal plane exercises, hip extensions. So anterior chain, posterior chain. I know a lot of people really focus hard on posterior chain. Don't always compromise one for the other. Do both. Frontal plane. Again, a variety of things. You can start in low level, open chain, then go to closed chain activities using weights, TheraBand, weight machines. Frontal plane adduction. Again, a variety of things. Copenhagen exercises are commonly used with something like this, illustrated on the previous slide. And then, Even though if somebody's rehabilitating patients with shoulder problems, we know the importance of the rotator cuff. Everybody does some IR, ER exercises in most cases. However, in the hip, I don't think we always adhere to that as much. And I think doing hip ER, IR exercises are as important in the hip as any of the other exercises. So we put a lot of focus on the rotators of the hip because they're your dynamic stabilizers close to the joint. So some different examples, and you'll see some at the very end of the case. So again, you can do that in many, many different ways. We're limited by our creativity in the rehab. And that's frankly one of the things that makes rehabilitation fun. Remember, it's always about functional rehab. Don't forget the first three letters, functional, fun rehab. So challenge the patient, add different exercises. I rarely will give the patient the same exercises every day. That gets boring. Furthermore, I might have a list, say, okay, there's 5 exercises we want to do for the hip rotators today. You pick 3 or you pick 4. That way, that gives the patient more ownership of the rehab program. And that way, if they don't like one, they can eliminate that one that day and do the others. So again, patients like to have some autonomy in their rehab as well. Then for the internal rotators, that's the weakest muscle group, by the way, because you only have the TFL and some of the anterior fibers of the minimus and the medius that are internal rotators. So that's a really weak muscle group. But again, some examples. Now, moving on to the knee. Again, obviously quads, open chain initially at the bottom. You can see your quad setting, getting that heel pop. So again, not only doing the heel to extension in the middle, but getting that heel pop, it's called, for the lower left, where that heel, most people have a little bit of recurvatum. As I said, the AAOS says 10 degrees. So we want to be able to get that heel off of the table with that bolster under the knee. And then again, doing it in an open chain position, then as you can see, doing TKEs with a TheraBand and with a ball. So it doesn't have to be fancy equipment. Again, looking at the progression, here's one example of progressions of exercises for the knee. And this is published again in Sports Health Journal, the journal I mentioned that I'm one of the associate editors for. So it gives you progression exercises, starting with, again, limited arc quads into, so short arc exercises to full range, light resistance, heavier resistance, and it gives some numbers. And these individuals have published extensively on ACL rehab. But other examples, your ACL, of course. Getting into the weights, whether you're doing open kinetic chain or you're doing closed chain leg presses. Again, progressing many, many variations. I actually, when I teach my students, I show them 50 variations of squats. So again, you're limited by your creativity to make it good variety for your patient. The other thing that's important, look at this diagram. This is, I think, very interesting. When you look at doing a squat, if you want to minimize, say, an example of forces on, say, the ligaments, then different parts in the range of motion. So your peak ACL forces are up here. So way down here from full flexion up to 90, very minimal stress to the ACL. So again, if you have a patient that you're concerned about their ACL, then you work them in deeper planes of squatting. Whereas again, if you want to work the maximum quadriceps, here you can see the maximum EMG for the quads is in this range of motion down here. So again, it allows you to customize what you want to do with the different parts of a squat. So that's a really an informational, if you will, type of guideline for squatting. If you're concerned about somebody's ACL, then obviously you have the maximum shear forces as the knee goes to terminal extension. You get your obligatory screw home mechanism to the closed pec position. So again, that's where you get your maximum anterior shear forces on the ACL. So obviously early in rehab, you would minimize that. do more open kinetic chain exercises in the deeper ranges of motion. So that's a really good example of looking at the shear forces on the ACL, looking at where you can get maximum recruitment of the quads or the hams. If you're looking at the PCL, that's not as common, so we won't even bother with that right now. Okay, so again, your knee flexion, again, a variety of things starting from simple chair slides into using TheraBand. But remember, a lot of people, we work a lot of quads for the ACL. But remember, the muscle group that prevents the anterior sagittal plane translation that stretches the ACL or the hamstrings. So again, they both need to be focused in ACL rehab. That's why sometimes, again, I know in Europe, they do a lot of ACL reconstructions using the STG, semitendinosus gracilis. To me, they are the most important synergistic muscles to prevent the anterior translation of the tibia that stresses the ACL. So again, to me, those hamstrings are just as important to minimize that forward motion to protect the ACL both before an injury and frankly after a reconstruction. So at any rate, just things to think about with your hamstrings. And obviously there's a bunch of ways you can do that, as you can see, manually on resistance, moving a TheraBall, step ups, then moving down to the ankle again, ankle plantar flexion. A variety of ways you can do that from manual to machines. Don't forget, again, straight knee, bent knee, because your straight knee gets gastrocs, your bent knee gets soleus. Then into your dorsiflexion. Then again, you can do machines with that as well. Somebody mentioned again for inversion, again, manual, TheraBand, weights, etc. But then eversion. Now, again, somebody mentioned doing fibularis as one of the ACL grafts. But again, there's only two muscles out there. When the ankle is most commonly sprained joint in the body. When that ankle goes into plantar flexion inversion, the only dynamic stabilization that's there is your fibularis longus and brevis. So again, if we harvest one of those for an ACL reconstruction, we're really compromising that lateral ankle stability. Particularly, they're going to use the fibularis longus, which has the longest tendon, of course. And then the only thing that's left is the fibularis brevis. And that guy is not that big and is not that strong. So again, I think that's one of the reasons we do not use that tendon very often. Because again, looking at that ankle, the only thing that controls that are a bunch of tendons crossing the ankle. So that's why proprioception training is more important in the ankle than just strengthening. Because again, those muscles help dynamically control it, but they're not directly crossing the ankle joint to stabilize it. Like in some other joints, like in the hip, it's more so much muscle to stabilize it, whereas very few ligaments there to stabilize the joint directly. So again, that's one of the reasons, again, that it is rarely used, at least in the US. And there's a bunch of ways that you can do that, as we all know. Again, progressing it to some weight, some non-weight bearing into some functional things with wall slides, step ups, lunges, etc. So phase 2, we're doing emphasis on total leg strengthening. There's no one way to do it. There's a variety of exercises that you can use, but the most important take-home message from this part of the presentation is start with the core and make sure you work the core all the way through. I think most of that was pretty straightforward, Amar, so I doubt if there's a whole lot of questions.
Yeah, we have a couple of questions here.
Okay.
The first one here from Dr. Mahmoud Ragab, and he's asking, many studies suggest and encourage using closed kinematic chain exercises initially instead of open kinematic chain exercises. Many clinicians are reluctant to use open kinematic chain exercises due to strong beliefs that they might increase graft laxity and delay ligamentization, while other studies and researchers encourage incorporating open kinematic chain exercises early as soon as possible. So what's your opinion on that?
Great question, by the way. And I will say for the last 40 years, we've all been concerned as therapists by doing open kinetic chain with ACLs that we're going to stretch out the graft. The reason for that, there is some early literature by Benyon et al., where they actually put force sensors into the ACL, had people do a variety of exercises. And of course, as I just described, when you go to turn, and that graph I showed you that shows where the most stress is on the ACL, when you go to terminal extension, you obviously get anterior translation of the tibia, you get external rotation as part of the screw home mechanism, you go into the closed pack position, which yes, that then tensions the most stress on the ACL. But what has been shown, if you avoid open kinetic chain exercises for the first 4 weeks, and then after 4 weeks, then you will increase using it. And I'm going to show you studies later, a little bit later on the actual studies. There's several recently by Forbelli and published within literally the last couple of years that show that doing open kinetic chain exercises after about 4 weeks to 6 weeks is safe. The reason that is important, again, you can squat all day long, but again, the biggest, strongest muscle in a squat is the hip extensors, the butt. Whereas again, the only exercise that isolates the quads are doing open kinetic chain exercises. So that's the reason we need to do an integrated approach. Don't do it real aggressively in the beginning. I showed you that one graph there that showed where the strain is. So avoid 30 to 0, the early phases. But you can start doing open chain exercises from 90 up to a 60 early on. And frankly, that's one of the best places to optimally recruit the EMG of the quadriceps muscle. So again, you need to get the quads as strong as you can early on to prevent the AMI. But also there was other studies coming up later that show you the safety of doing the open chain exercises safely in the appropriate timing factor. And then you can read those articles directly, but they're in your handout. We'll get to those in a little while. Other questions?
Yeah, great. We have another question here, and he's asking, is deep squat is better than mini squat in quad strength and cause less shear force?
Yeah. Early on, I would think that, again, as I said, you would do some mini squats or short arc squats. And then again, if somebody, and as we know, about 80% of people that have an ACL injury also have a meniscus problem. So if they've had a meniscus tear, the last thing you want to do is do a deeper squat. Because again, when you squat or flex the knee, the medial meniscus migrates 6 millimeters posteriorly in the joint line. The lateral meniscus migrates 12 millimeters in the joint line. So the point is, when you squat, the menisci migrate posteriorly in the joint. And if they've done a meniscus repair and you're squatting, that can compromise the healing integrity. Because again, that all your meniscus tears don't always heal real great. So starting with short arc squats and then progressing to deeper squats is typically how most people would do that following ACLs. I think that's answered the question.
Yes.
Yes, no?
So nothing new from the chat so far.
Okay. All right, moving on. ACL phase 3. So this is the terminal phases. Obviously, hopefully you regain proprioception, balance, strength, hopping, performance, and agility. So at this point, again, here's some objective metrics you can use as guidelines. There's nothing sacred about this, but I will use the generic term. Typically, you want to look at limb symmetry and you want to look at allometric scaling. Normalize the data to the patients. So that's an example, but this is pretty much conventional data that's in the literature right now. We'll elaborate on that when I get to the return criteria. So again, just a couple of things. These are some guidelines that you want to go through, and these are very generic, but you always want to go easier to harder, progression, overload, always include the proprioceptive training, good alignment, and again, strength, power to endurance. One plane of movement to multiple planes to triplane movement. So having them run straight, then having them do a gentle 45-degree cut, then a 90-degree cut, and then a crossover cut, things of that nature. And again, with everything else, isolated movements to multiple movements. non-weight bearing to partial weight bearing to full weight bearing, open chain to closed chain to functional stuff, limited range, full range, slow, medium, fast velocities, part movements to whole movements, concentric to eccentric to combined, concentric to counter movements being plyos, and then isometrics into dynamic ballistics. So there's some of the principles of progression and overload that need to be incorporated into terminal phases of rehab. Again, similarly, when you get into functional, one movement, stick it, multiple movements, stick it. It's like instead of a single hop test, a triple hop. One movement with repetitive movements. Proactive movements, and we'll get into this in the discharge, proactive movements to reactive. Most sports are reactions. And then general movement patterns to specificity. Not enough there. I'm going to keep going. So one of the things that we have to do is we've learned that an ACL injury is also a brain injury. So in other words, has testing really evolved with the ACL to test the brain? So a knee injury is also a brain injury. Neuroplasticity is the concept of the ability of the brain to change. So how can we train it? This is an important slide. You see each of these parts of the brain are influenced with different exercises. Each of these different parts of the brain also become injured with different types of injuries. An ACL, we know, sort of affects everything. But as an example, there's recent research. We've done some things in the upper extremity as well, that as an example, if you have instability in the shoulder, it affects parts of the brain. But if you have cuff problems, rotator cuff problems, it affects other parts of the brain. So current concept of neuroplasticity following brain ACL and brain injuries. So here's an example where we know that they've done functional MRIs that after somebody has an ACL injury, different parts of the brain are different compared to normals. So that's the whole idea of the neuroplasticity that's occurring. Furthermore, when you do different exercises, that influences different parts of the brain. So the brain neuroplasticity, all of this stuff happens. And again, as I said, what the primary thing is we get compensatory changes occurring and you become much more visually motor oriented. So you use vision much more to compensate for those little nerve receptors in the knee that were injured with the ACL injury. So consequently, it's an adaptive change. This is the sequence of going from the neuroplasticity, increasing proprioception, to the motor neuroplasticity, to postural control, and to having your good movement patterns. Lots of research in this area. Over the last decade, there's been tons of research. Now, another important slide. Look at this. I showed you that one slide that showed the different parts of the brain. Now, here's a neat slide. Look at the different sports that are occurring in different parts of the brain, and then look at the different activities that activate those different parts of the brain the most. So I'm just going to use one example. Down at the bottom, if you look at somebody, if they have an injury that affects the cerebellum, you use what are called open skill activities. That means something that you react to. Whereas if somebody has an injury that affects the temporal lobe, there you use closed skill activities as part of the rehab. Closed skill activities are predetermined. You know you're going to do a certain movement pattern, whereas your open skill is more of a reactive response. To me, this is the future of our rehab. That, again, as we learn more, we're going to learn what parts of the brain are most affected, and then we can customize specific exercises that have all these components where, again, just using the cerebellum. Coordination type of exercises, skill and motor learning exercises, and open skill exercises. So again, we don't know all the answers for the ACL yet because it affects so much of the brain, but we're getting closer with different things. So using the temporal lobe as an example, It's going to use different types of cardiovascular exercises, closed skill exercises, meaning you know you're going to do squats, and a few of these are for humor. And then general physical activity, just general movement patterns. So there's an example of 3 ways that are going to affect that. If we look at occipital lobe as an example, you see the 3 types of exercises that will influence the occipital lobe the most. So here you go. So doing something that is a hop test. That video is not working. We'll see that later. Then visual demands. So using different lights for them to respond to visual demands. And then down at the bottom, some type of motor control where they go to different numbers that are allocated on the cones, always returning to the central cone, using different external targets, using stroboscopic glasses. You'll see this later on. This is one of the important things because, as I said, with an ACL, they no longer have the normal mechanoreceptor proprioception in the joint. They have to rely more on vision. So using stroboscopic glasses interferes with that. Going on to parietal lobe. Again, you can see the different exercises. Again, sensory rich exercises. So having somebody dribbling a ball, touching a light pattern, and doing math in their head, doing the hop test type of exercise. And then down on the bottom, again, object-based activities. So using external focus of attention. So he needs to hop over the cone. So these are things that, again, facilitate that part of the brain. Other things, throwing balls at different lights as they light up, are going to stimulate with the external focus of attention with the environment. Moving on to the cerebellum, as we just said. So doing different types of coordination type of exercises, skill and motor learning and something like martial arts. And then open skill exercises, something like basketball. So the opponent doesn't know what the offensive player is going to do. And then finally, the frontal lobe, which is kind of the command center, if you will. Then again, cognitively demanding exercises. So doing reaction drills. So if you have 2 patients that are pretty similar in rehab, then have them do reactions against each other. And that's the way you get the reactive training in milliseconds. Open skill exercises. So looking at something like handball. Again, she's reacting to the opponent as to where she's going to throw the ball. So the goalie is in one part, so they're going to throw obviously to the other part of the net. So that's open skills or reactive skills. Again, doing dual tasking. So this guy dribbling a basketball with stroboscopic glasses and catching a ball and throwing a ball back. So numerous sensory overload, if you will. Again, using virtual reality training. Other areas with there would be, again, doing concentric exercises. So doing something like pressing partners up, resistance training using eccentrics. Don't use too heavy of a weight. That's not good. And then lastly, mind-body exercises. You hope everything is working together. So again, these are just examples. All right, so there, we're going to segue into more exercises, and then I want to get to make sure I can keep going. So if people need to take a break, go to lunch, bring them back, listen, go get something to drink, whatever, I'll just keep going because I want to make sure we get through everything, because I just have a lot of stuff that I'd like to share. Any questions at this point, Omar?
No questions on this part so far.
Okay, good. As I mentioned before, we have aquatic treadmill, so we can have the patient doing exercises. She's a volleyball player and has had an ACL. And as I said, ACL, medial meniscus, lateral meniscus repairs, and an implant brace. So because she's a volleyball player, she's also working the shoulders. She's a setter, so she has, and one of our best servers. So not only has she done things with the lower extremity, but she's also working upper extremity, doing quick step type of movements. So these are some of the things that we've done in the terminal phases of the rehab, doing vertical jumps. This is a tough exercise. He's using CLX TheraBands. So not only is he getting some active movement of the hips, the lower extremity, but the upper extremity and the core stabilization. So we call those X vertical jumps. Here's an example doing quick stepping. You'll see this patient a little bit later as well. So quick step exercises. lateral jumps on an unstable surface. Talk about kinesiophobia. Look at her eyes. So we have a spotter there, though, and we build up to this. She just jumped on the floor first. Now we're jumping. We had a very, like a Spenco pad, single pad. She jumped on, and so it was a little bit unstable, but it was stable. And now we're going to a very unstable surface.
Okay.
So again, but there's a spotter there as well. So again, and then we do it to the front. Once again, I'm going to stop that for a second. And I don't know if you can see, but this patient has had 16 knee surgeries, 9 on the left side with a patelectomy. So she was a soccer player or a football player all through high school, college, and it had multiple injuries, dislocating patellas and all that. Ended up tibial plateau fracture on the one side, several surgeries, but then had, again, on this side, she had lateral releases, MPFL reconstructions, they failed, an anterior medialization of the tibial tuberosity, all kinds of problems. But as you can see, doing pretty well and heading back to light activities. Then we do different shuttle testing with blaze pods. So again,
Come on,
shuffling to the side, touching
What
pink.
was that? Come on.
She's
just
going in
wait.
slow motion,
Go,
but
keep going.
need to go a little bit faster.
Touch
and
it.
touch and go. She shouldn't be
Don't stop.
stopping there. She should keep going.
Keep going. Come on. Keep
So
going.
again, so resisted side running
Good.
is again,
Good
and she
control.
actually has a total patelectomy. And now front running, she does better with the front running, as you'll see. So good straight sagittal plane movements. So again, front running, just different functional things for fun for the patient. We use the blaze pods as motivation for them. Now, some other examples of using exercises on an unstable surface. So here's the patient again, and I have permission to use the videos that she's the ACL, medial meniscus repair, lateral meniscus repair, and an internal brace. So on an unstable surface, now because she's volleyball setter and she's our primary server, notice she's going to be starting to move perturbations in the arm. But again, braced on an unstable surface. And she's only a few months out from all that. All right, now we go to using a hex stick. So she's on an unstable surface using the flex bar for the shoulder because she's a server and she has to multitask by catching that. We throw the hex bar, we call the color. She has to call the color, catch the color. So again, that's difficult. From there, it's a similar one. I'm just going to skip past that. So she's doing the same thing. We use that as part in different days of rehab. But you notice she's catching the bar. Now, again, here's another variation. I have TheraBand around her doing perturbations at her. So if she's going to set, the volleyball's coming down, somebody else may run into her. So we actually make them do the perturbations with the arm for serving, unstable surface, catching the ball, the hex stick, and I'm pulling the cable. So that's tough. I mean, there's so much going on. We're trying to replicate somewhat in the clinic what's going to be happening in a real world situation. So lots of stuff going on there. So now the last thing, and I just added these slides, but we use the strobe glasses as well. This is hard. So she can hardly see what's going on. So again, she'll catch it soon. So the strobe glasses are doing that. So it's constantly obliterating her vision. So she can hardly see. It's almost like being blinded, but she has to rely on the proprioception of her knee and body to be able to catch the right color on the hexa stick. So, and again, we now add it, make it harder. She's on an unstable surface with the stabilization for the serving arm and catching. I mean, with the strobe glasses, that is really, really difficult to do. So unstable surface, flex bar, catching a hexa stick, strobe glasses. Wow, that's tough. So at any rate, now we're just going to throw in some volleyball. So now she has the strobe glasses on, and now she has to hit the volleyball in all different positions. So again, doing different things like that are the progressions in the terminal phases of rehab. We can never replicate in a clinic the actual demands are in sports, but we try to do all those different things with the multi-sensory stuff and an integrated pattern, trying to replicate what's happening in a sporting environment. So if somebody's playing football, let's say a goalie, they're in the soccer goal. They're looking at the ball, but they're also looking at maybe a wing running down here. Somebody else here is a forward striker. So they're looking at everything. So that's why we have that multi-stimulation of patients. And that was just an example of some different things we do with the patients in the clinic. Always think of layering things. So start with the very basic, as I said, you build a house, you put in a good solid foundation. We've done all that. Now we're layering up the sides and the roof on the rehab program. So what we're trying to do, even at that point, as you saw, unstable surface first. Then we add something like a flex bar because she's a server in volleyball. Then we add an unstable first surface flex bar and now have her catching something. Now we have the unstable surface flex bar catching the hexa stick and then having the TheraBand around her doing perturbations. Then we do the unstable surface, flex bar, hexa stick, perturbations with strobe glasses. So we keep layering things. Make sure they're reasonably good at the first stage before you layer up too much. So they were just quick examples that I showed you. It might take her a week to progress from one level to the next and some of the things we're doing with her. So any questions at this point?
No questions came up from the previous section. No.
Okay, so now let's start talking about what are we going to do for return criteria for the lower extremity. So again, we have to think about a very systematic way of getting people back to their sport. So right now, again, this is the last part of what we're going to talk about here. And then I have the hamstrings at the end with a case at the end. We should have time for that. But now let's talk about criteria for return to sport. And this will take us a little while. So return to sport activities, again, these are some of the things that need to be included. The first thing is PROs. How does the patient feel about how they're doing? So particularly for the knee, we need to look at something like the International Knee Documentation Committee. That's one PRO that's universally, internationally used most commonly to describe how the patient feels about he or she is doing. Then we need to add the ACL RSI. This is the ACL Return to Sport Index. This is the specific way to look at kinesiophobia with patients who have ACL injuries. The Tampa scale is the generic scale that's used for kinesiophobia, but the ACL RSI is a dedicated scale. That's the one that we should be doing specifically for ACL return to sport. So they're all, again, the patient-oriented factors. So we always have to know how they feel they're doing. Then we go to multiple testing. Again, there's a variety of tests that need to be performed, and we're going to go through that very systematically. And then, obviously, even though they pass all the tests, they return to their sport, they return to competition, they return to performance, then ideally, they're going to continue with an injury prevention program can be implemented to help prevent any reoccurrence of the injuries. So that's where we're starting. All right. So implementation of a maintenance performance program in ACL prevention. Again, the literature shows should be done at least a couple times a week, should include dynamic balance for that proprioception, should obviously include muscle strength, power, and endurance, and then it should be performed for a minimum of 6 weeks. That's even after they've returned to their sport. So again, and that's what we call the injury prevention program, so to speak, or injury prevention, re-injury of the activity. So what are some of the testing and criteria that we're going to use? So again, we talked about the criteria there and what it should be done. So what do we do in 2026? All right. So this is an overview slide. I'm going to spend just a minute with this and then we'll go, and we won't hit all these, but we'll identify some of them. Up here is what we just talked about, your biopsychosocial and your psychological factors using the ACL, RSI. So that's your PROs. Then we, as we've discussed, we need to respect soft tissue healing and time. Down to modifiable risk factors. We now know that the tibial slope is a risk factor for patients with ACLs. We can't change that unless they do an osteotomy. That's a big surgery. But other things we can modify that will be listed. If somebody has parents or a sibling that has ACL, we now know there's a genetic predisposition for an ACL to occur. Education and shared decision making. All the impairments, these are the things that you and I typically do every day in the clinic. So your strength, range of motion, your strength measurements, your power, rate of force development, endurance, and proprioception. If you have the access to some of the sport science stuff, the technology, the biomechanical testing, using GPS, IMUs, motion capture, force plates. If we don't have that, we do a lot of our functional movement tests that we'll talk about systematically. And all of those are used for return to sport criteria. But what's missing is this. The neurocognitive reactive multitask specificity in ecologically valid testing environments with fatigue conditions. I'm going to address that at the end because that's the main area of our research right now. So at the terminal end of what we're doing, that's what we'll address. All right. So we know, again, these neurocognitive reactive things are really important. So we'll be talking a lot about that as well. But through ecological dynamics, ecological concepts just means, does it really replicate the real world? So again, if we're talking about ecological validity, which is a term that comes from the psychological literature, ecological validity means, are you really testing things that are applicable to the real world? And again, if we're not, then we have to really question why. So using ecological dynamics, we design both our rehab and testing and training to meet the demands of competition. So again, we're going to start with this example of a study, which is very interesting, a meta-analysis of meta-analyses. There aren't many of those in the literature, but the simple bottom line, we've been dealing with ACLs for over 50 years now. However, there's still no consensus or validity of what criteria should be used for return to sport. Again, it's all over the board. It's like the Wild West right now. I'll share with you what we're doing and some examples of things that I think are very appropriate. All right. Recently in the Medicine and Science in Sports, there was an article from the ACSM organization talking about importance of optimization. But what they looked at, which was really, to me, quite impressive, over 500 references. And one of the things that they really emphasized is adoption of sport-specific testing. So that's what we're going to talk about. All right. So what are some of the changing dynamics of lower extremity testing? As I said before, we can never replicate in the clinic what the actual demands are in full-blown competition. The reason for that is all of this stuff is happening during competition. So there's crowd things, there's external competitors, the psyche of the patient, the adrenaline dump that we get competing, the warm-ups, the forces imposed on the patient, the medical staff stresses, distractors, the opponent and the chaotic environment, the coach's stress. But I want to emphasize these two are probably the two most important. That usually in sports, most injuries occur as a reactive response. And secondly, most injuries occur in milliseconds. So that's the key. So with that as a backdrop, Even though, admittedly, we can never replicate the demands of sports in the clinic, we have to do something to test the athletes for clinical decision-making, for rehab progression, as well as return to sports to get better results. So we're not doing a great job with that right now. When we look at some of the research, return to sport rates after ACLs varies. About 81 to 82% return to some type of a sport after ACL, but most of those are at low-level recreational sports. Only 63 to 65% return back to the pre-injury sport level, even if it's at a recreational level. Furthermore, only 44 to about 50% return to competitive sports at the same pre-morbid level of before. So they're not very good results. Along with that, about 20 to 30% and actually get re-injured, tear the same side or tear the opposite side. Nowhere else in orthopedics and sports do we accept a 30% re-injury rate. So again, as I just said, we're not doing a good job. The majority aren't getting back to the same pre-performance levels of sports at high performance, and there's a 30% re-injury rate. Wow. Well, what tests can be used? As you can see, there's a variety. What background information? This is an interesting study by Hadley. What they did is they basically did a systematic review. So they basically looked at a systematic review of, I think it's about 70 articles, and then they developed a checklist. What are some of the tests that are validated for criteria to return to sport? So again, I said 70, there's 60 studies. They found 7 criteria were included, and we'll go through those as we progress along. Their conclusions: prospective validation of our checklist, those 7 criteria, demonstrated that patients who successfully passed the checklist before returning to play experienced a significantly lower incidence of ipsilateral ACL injuries compared with the patients who did not pass the checklist. So keep that checklist concept in mind, because we're going to come back to that shortly. So my mantra is test, don't guess. So we recommend using that checklist or an algorithm-based approach to rehab. An algorithm or a checklist is nothing more than a process of steps, with each step predicated on passing the previous step. It's a quantitative, qualitative functional testing algorithm, or a step-by-step process for clinical decision-making to return people back to sports. So think of it, again, as a checklist that not only allows us to progress patients through rehab, but it also serves as a guide for clinical decision-making for treatment interventions and criteria for return to sport. Interestingly, the first article I ever published when I was the head athletic trainer at a college was a checklist for the athletic trainer on game day. And the interesting thing, that article was published over 50 years ago. 50 years later, I still use a checklist as a physical therapist, athletic trainer for rehab. This is one of the articles we published, individualizing the return to sport after ACL reconstructions. And what we did, again, is this is the test. They pass this test, we move to the next level. We pass this test, they move to the next test. They pass this test, we move to the next test. If, as an example, however, they do this test and fail it, then we go this way and rehab them with the focus on that criteria until they pass it. Once they pass it, we move to the next level. So it's a step-by-step progressive hierarchy of testing. Again, that concept is predicated on this book called The Checklist Manifesto. And again, the subtitle of that book, How to Get Things Right, is the key to me. Again, a good example. You don't try to do a lot of strengthening with a patient who's got an ACL in the early phases. because they have AMI. So it's counterproductive. It's not going to be useful. You have to get rid of the effusion, the pain, and the AMI before rehabilitation for strengthening is even going to be effective. So that's the example that shows that it has to be a systematic approach to rehabilitation. Again, here's another article we published with the current president of the AOSSM, and again, a couple therapists, a couple physicians. So those articles, again, you can find those and use those as criteria. So again, to summarize that, we look at basic measurements, force expression, and then functional testing. All right. So, whoop, oh, that's the end of that guy. Let's go to this one. So back to the premise of test, don't guess. What do? So strength and functional testing during rehab, again, many people just use manual muscle testing. 56% of physical therapists in the United States with athletes use manual muscle testing. That's not enough. That's not good enough. That's not good enough. It's not enough to really use that as criteria to return back to sport. So again, with that, the reason is manual muscle testing is not strong enough to reflect the quad status for return back to sport. We need objective numbers. So either a handheld dynamometer or isokinetics is the gold standard. We need objective numbers. So this is now where sports science has helped us over the years, that we use, again, we have a Biodex in one of the clinics. I don't have it in another clinic. So I work in a couple different clinics, but we can do ACL testing using the Biodex. Once again, or the Cybex or Humac or whichever one you have. So again, we still do velocity spectrum testing. And again, you don't do that early on. As somebody raised the question before, obviously you don't stretch a graph. So you wouldn't even do some of the testing like that because you're not going to do really high-level functional stuff until a few months anyhow. So we don't even do the Biodex testing until about 3 months. So with that, again, we need to look at the data. Lots and lots and lots of numbers. So obviously you always look at limb symmetry. So the uninvolved side compared to the involved side, and then you do allometric scaling. How strong is the patient compared to their size, or normative data, or patient-specific data. So here again, this is a summary. We published one of the books on isokinetics, the first book on isokinetics, over 40 years ago. So we look at bilateral symmetry, limb symmetry. We look at unilateral ratios, quads to hams for the ACL patient, torques to body weight. That's your allometric scaling. We look at total leg strength. So even though we use the isokinetics at the knee, it's not practical to change that around for proximal distal muscle. So we use handheld dynamometry at the hip and the knee, or sorry, at the hip and the ankle. You can look at angle-specific torques, endurance testing, normative data, sport-specific testing. So all of those are available to use. This is just an example of angle-specific testing. Somebody asked before about you don't want to do a lot of exercises at the terminal ranges of motion from 30 to 0 with an ACL. First several weeks, you don't. But after that, you do. But think about this. Where do most knees have the ACL injury occur? It's not down at 90. It's not down at 60. It's at 30. That's why we have to strengthen that area using the quads to get the isolated strengthening of the quads, because that's the angle-specific strength that's going to maybe perhaps minimize the ACL injury and or re-injury. So that's why angle-specific torque, angle-specific training is important, but at the right time, based on all those criteria I said, soft tissue healing, etc. All right, so with that, again, we know that the isokinetic testing at 60 and 180 degrees is a strong positive predictive value of functional testing. So everybody says, well, you're sitting there doing that. that's not functional. No, it isn't functional, but it correlates pretty closely with functional tests. Other examples of the information: early resolution of quad strength deficits improves kinesiophobia, improved confidence, quad strength of the to body weight with isokinetic testing is a good association for people who return to sport at 6 months versus those who do not. So again, another example, those who failed return to sport criteria had a 38% re-injury rate. Those who passed return to sport criteria, a 6% re-injury rate. But look at one of the criteria that they used. More symmetrical quadriceps strength prior to return to sports significantly reduced the knee re-injury rate. And there's the reference, so you can go back and look at that. So there's a lot of literature that shows that again, we need to do some testing. Again, patient-reported outcomes, kinesiophobia, strength tests, functional tests, all are related. So now, if we don't have an isokinetic device because they're expensive, then we can use a handheld dynamometer or some type of cable tensiometer. But just a couple of suggestions here. Again, this is an article that shows the validity of using a portable dynamometer versus an isokinetic device. However, this is the position they're testing in. And if we look at that again, one, that's not the position of the hip with function. And two, nobody hurts their knee at that position. So my question is, that's not a functional knee position. Nobody injures their ACL at that position. So why has that become the gold standard? Because it lacks ecological validity. Even though it may have validity, comparing isokinetics to the cable tensiometer, it doesn't have ecological validity because it doesn't apply to the functional positions of the hip and the knee. So if using handheld dynamometer, I'd recommend you do it at multiple angles, probably a minimum 90, 60, 30. Furthermore, as we talked about, put the patient's hip in a position that replicates standing, walking, and running. Plus, remember, isometric testing is not dynamic muscle performance. So there's the example that I used before. Put that knee at different positions and put the hip at different positions for the testing. Here's an article. Can isometric testing substitute for squat testing or dynamic testing? No, it cannot. Another study, a meta-analysis, does the relationship between isometrics and dynamic strength be the same? No, it does not. So again, we can't just arbitrarily substitute that, even though that's a good position, with numbers. So again, what we need to do is we need to assess the hip and the knee movements relative to ecological validity, replicating sport-specific positions. So we don't walk around in that 90-degree knee flex, hip flex position. So what are some things we need to consider? So instead of testing like that, look at the hip position with kicking. That's the hip position for testing.
Right.
So we should have somebody in that position for the testing. So having them do the quads and the hams are different based on the length tension ratio. So that position of the hip replicates the kicking position as you saw in the previous slide, or the standing or walking positions. So again, using that position is more ecologically valid. So again, there's other examples that show it. Now, again, is the data different? Yes, it is. We published this article, The Influence of Hip Flexion and Isokinetic Velocities on Quadriceps and Hamstring Strength Ratios. So that's what I just said. So I'm not just recommending you do that because it might change things. It does change things. So again, the influence of hip flexion and extension, again, on quad ham ratios. And there's the literature. You can look that reference up. Again, there's just the tables that show the differences, and they are statistically significant. So again, the article adds that for return to sport testing, we need to include isokinetics ideally because it's dynamic and you can use angular velocity testing. Now, admittedly, it doesn't test at the fastest angular velocities of true sports, but again, we can test at faster angular velocities that replicate some movement patterns. Now, once again, the question always comes up, well, wait a minute, sitting there doing an isokinetic test doesn't correlate with closed chain functional testing or performance. Well, there's a reference, 805 references from just last year that do show that isokinetic testing does correlate with functional testing. So there is a correlation with that. So again, when somebody asked the question about the rehab, here's the answers. This is the first study. So whoever asked that question, you need to get this study. So this is by Forelli. And again, evaluation of the strength and the graph laxity with early open kinetic chain exercises after ACL reconstructions. So again, a cohort study, Forelli's the senior author, in OJSM, that's open access, so you can get that today. And bottom line, you can do the early exercises after ACL reconstruction without increasing graph laxity. Another study by Forelli, intrinsic graph laxity variation with open kinetic chain exercises after ACL reconstructions, a controlled study. One more time, using the open kinetic chain exercises to increase the, or open kinetic does not increase the ACL graph laxity. And finally, physical therapy and sport, effects of open kinetic chain exercise during the first weeks of ACL rehab, reconstruction rehab, meta-analysis. High heterogeneity limits strong conclusions, but what it does show is open kinetic chain exercises influences the strength of the quads and hams because you don't have all the other muscles, the big hip extensors compensating for a weak quad. And when you do squats, again, the hip extensors are the strongest muscle, not the quads. So again, as it says here, early open kinetic chain exercises, less than 4 weeks, 90 to 30, it rarely will increase laxity, but it's safe. So again, and then best results were seen when open kinetic chain exercise were reduced at the 4-week mark. And then again, we need more research, as we do with everything. So whoever asked that one question, it's a great question. And for 40 years, we were always concerned about that. But there's 3 recent articles within the last year that addresses that very question. So again, you don't go crazy and do OKC exercises in the first 4 weeks, obviously. But after that time, we need to get the isolated strengthening of the quads. That's the key. And by doing closed chain exercises, it does not isolate the quads. So something to think about. All right, so moving on. Okay, let's stop there for a second. Any questions at that point?
There's no questions at the moment, but the audience
All
will.
right. So what do we do in 2026? Here's what I do with the patient. They walk into the clinic. First thing we do is all their lower extremity closed chain testing. We always do 4 progressive gradient warm-ups. We do a 25, 50, 75, 100% warm-up. We do that because I think that's a fail-safe system for me to make sure that I'm not going to test somebody who's not ready. My clinical judgment says they're ready, but as they actually do the 75 and 100% warm-up, you notice they compensate. They have that look in their eyes with fear. So again, to me, that's a good guideline. So the first thing we do is a jump test. That's 2 legs. They concentrically push off, eccentrically land. Again, many times, though, they're going to compensate and land more on the non-involved limb. We talked about that before. We did that study with the and the Smith squat rack where we show they unload the involved side up to about 6 months. But nevertheless, we always start with this test. Again, we don't have another side to compare against. So what do? We do, again, allometric scaling. So males, we want them to jump 100 to 110% of their height. Females, about 90 to 100% of their height. All right. So here's an example in NFL Combine. This guy's 6 feet tall. He jumps over twice his height. So again, jumping your height is reasonable. All right. Now we go to single leg. This is the most commonly used test in the literature. The American Academy of Orthopedic Surgeons, when they look at all the testing, as you can see, the first 4 of the 5 tests are all hop tests. Single leg hop, triple hop, crossover hop, timed hop. And then obviously the IKDC that we've talked about. Then comes isokinetic testing. All right. So again, with a single leg hop, there's over 5,000 patients in this study, which is old now, but it's a systematic review with over almost 100 studies. But at any rate, hop distance symmetry moderately reflects knee biomechanics. So again, we have to look at it, but again, don't use a single leg hop test as criteria to return somebody back to sport. No sport does that. So even though it's a good test for part of the testing battery, it's not ecologically valid, meaning it doesn't mean that it's replicating what somebody's going to do in a sport. So we look at the qualitative and quantitative aspects of that. So again, the quantitative aspect we measure, the qualitative aspects is your qualitative assessment as a therapist. We as physical therapists are the best there are at qualitative assessment because we see so much movement patterns. So here's an example. The quantitative distance for her to do the hop is the same, but obviously this patient qualitatively is not ready. The non-involved side, the knee is pretty much straight ahead. Look at the dynamic valgus and the rotation on the involved side. So even though quantitatively it's the same, qualitatively she's not ready, needs more rehab. So with the hop test, first thing is obviously limb symmetry. So they need to be the same. We want them 90%. But then we do the allometric scaling. So for males, we want them 90 to 100% of their height, females 80 to 190% of their height. Again, I've used that word over and over and over, ecological validity. It comes from the psychological literature, just simply means, does it replicate the real world? So here's another study. Hop distance to body height ratio outperforms just limb symmetry. So that's why we do the allometric scaling. Another study, again, the hop performance may mask relevant strength deficits because you're testing the whole lower extremity. And we don't know if they don't do well, is it from the hip, from the knee, from the foot and ankle? Furthermore, single leg hop for distance masks lower extremity biomechanics. So as we look at this study, just look at the light green. When you do either the horizontal hop, the hop test, or a vertical hop, again, the takeoff is the same. So it's again, when you look at the horizontal hop, it's about 12% takeoff, but you look at the vertical hop, it's about a third, so it's 3 times more, about 30% more. Landing, look at the difference. With the horizontal hop, it's only about 12% effort to start a propulsive phase, but the horizontal landing is almost 2/3 of the muscle force. So that's that eccentric deceleration that's the key. And that's scary for the patient. Look at the vertical hop. Interestingly, it's the same amount for the vertical propulsive phase as the eccentric landing, 34, 34. But again, that's why I think both of these are important, but I think this is a key one because it's that eccentric deceleration on that hop that really has the patient's head into the game, so to speak, so they know how they feel. Furthermore, you can look at the qualitative aspect. Here's an article, you might want to look at this again, that's the qualitative landing scale. So basically you take this scale and you can just write yes or no for the different components to see how the patient is doing. So that's the single leg hop for distance and a lower extremity assessment scale. So again, you can do that as well. I think qualitatively as physical therapists, we're pretty good at just looking at it and seeing it, but here's a way to quantify it. Now, furthermore, the neurocognitive demands change things. So again, we published this article, The Need to Change Return to Play Testing Following ACLs, a Theoretical Model. So again, I'm senior author on most of these because I'm the senior person who's done most of the research. Kevin is a good a friend and colleague. We've done a lot of stuff together, but I'm the senior author, and your senior author goes last, your primary author goes first. So we work together on a lot of these. But the point is, with this, we looked at different ways to even change things using some neurocognitive testing. A simple way to do that, have the patient do a single leg hop. When they're in the air, you call which leg they have to land on. That sounds easy. It's hard as heck to do. So they take off on one leg. When they're in the air and you have to call it right away, then they have to neurocognitively react. They think about, they hear it, they think about it, then they have to make the change which leg they're going to land on. And you can even improvise other variations from that. But that's a simple way to, if you don't have a lot of equipment and various things, a simple way to do a neurocognitive reactive hop test. Very simple. All you do is call which leg they land on. Now, we've learned about the single hop, triple hop, total hop, crossover hop, and all that. And I want to just show when you do a neurocognitive triple hop, it decreases performance by about 7%. But we need to look at not just hopping in a straight line, we need to hop in all different directions. So the side hop test using the traditional one, 40 centimeters apart, side to side. Again, they do it for 30 seconds and they can't touch the line, blah, blah, blah. That's the normative values. So here's the test. So you count the number of times they don't touch the line. But the reason I'm including this, again, if we look at doing the medial lateral hop test, adding the neurocognitive aspect to it, it changes by about 10%. Now, if we look at the AAOS guidelines for criteria to return to sport, they mention the hop test, as we talked about before, for the five first tests, for their functional tests, or all the hop testing. But again, 33 functional tests, none of those are proactive. None of those are multitask tests that replicates functional performance. And as I said, that's why we got to do the multi-sensory neurocognitive testing. So we'll stop there to see, because we're going to segue into the next phase, which will be the neurocognitive testing. But up to this point, jump tests, hop tests, all good. But again, they don't meet the criteria for that ecologically valid testing. Any questions at this point, Omar?
There's a question here, and
Good.
he's asking, why do some patients with a positive Lachman test still have no obvious knee instability during walking? Can neuromuscular compensation mask an ACL injury?
I think I caught most of that. Patient with the ACL, why do they, is it compensate with something? Is that what the question was?
Why do some patients with a positive Lachman test still have no obvious knee instability during walking? Can neuromuscular compensation mask an ACL injury?
I think if a patient has an ACL deficient knee and they can do any of the tests, whichever one it is, and they can do it without compensating, then they're masking it. The reason they can mask it, Lynn Snyder Mackler with the Oslo, Norway study have shown that there are what they call copers. The majority of people that have an ACL injury cannot compensate well enough to do any functional testing. However, there's always a segment of individuals that are called copers. And the reason they can cope so well is, again, they have the neuromuscular dynamic stability training. They have good proprioception, good kinesthesia, good neuromuscular reactive rate of force development that they can compensate for any type of test, regardless of which type of test it is. And they're the group that are known as copers. Again, I think it's a smaller minority of people. And again, very few can do that at the highest levels of sports performance. There's very few individuals. There are a couple, of course, there's always a couple, but there's very few high-level athletes that are ACL deficient performing at the highest level. The few that are, they have such good neuromuscular dynamic stability. Their circuitry is better than anybody else's. That's why they can do that. I think that answered it. They're known as copers.
Yes. The audience is very engaged, but no new questions at the moment.
Okay, so with our testing, this is the consensus statement on return to sport. Return to participation, return to sport, return to performance. The key to this, though, for the ecological validity is here. We've already addressed this when we looked at the parts of the brain and different things like that we need to do a battery of tests using both open and closed skills and reactive elements. So we know that ACL injury occurs. We know there's changes in the brain. We've already addressed this. So again, we know the ACL was a brain injury. How do we test it? We've talked about it. So one of the things that we need to do is multi-stability testing. We've already talked about the straight up hop test. We actually published this article as a further development of the hop test. Instead of doing a hop test or a triple hop or whatever in one direction, we basically developed the T-drill hop test. Published that in this article, which is open access, so you can get this. Again, we had 50 subjects that did it just using a T-test. So here's the test. If you start on the left leg, you go to the left side first. If you start on the right leg, you start on the right side first. Very simple, only takes about 10 seconds to do it, but allows us to get a limb symmetry. So again, that's the test. So again, the ICC's test retest reliability doesn't get much better than that for a functional test. We use pair T-test, compare dominant, non-dominant. It's the same. So again, the beauty of that, it's no difference between a dominant side. It only takes about 10 to 15 seconds to do it, and there's high reliability. The limitation of it, it's all pre-programmed. They know exactly what they do. Plus, nobody just hops for distance in a sport. Okay. So then we said, well, we got to look at change of direction as well. So then we did this test, kind of looking at the person cutting, twisting, and pivoting in a sport as a change of direction, and it's multifaceted. So we looked at a change of direction, just going back and forth, 51 subjects, again, looking at the change of direction side to side, how they would do it. But the interesting thing we found, ICCs were good, as you can see. So the reliability was excellent. But the most interesting thing we found from that study, from time start to 10 seconds, no change in step rate, 10 to 20 seconds, no change in step rate. From 20 seconds to 30 seconds, every subject slowed down. So what that means, again, even though it's excellent reliability, there's a possible fatigue effect occurring as quickly as 20 seconds. So when we look at the energy systems used, we blow through the ATP PC system in a couple of seconds. Then we get into the phosphagen system, and then in the anaerobic glycolytic system. And that's basically used up in that 20 some seconds. And that's what we found. So a lot of our testing, again, either lasts too short or perhaps doesn't last long enough. So we felt we needed to develop a fatigue index as well. So when we look at the literature, I just ran this Medline just recently, knee and fatigue testing, there's almost 4,000 articles. Knee and fatigue and decreased performance, there's over 800 articles. We're missing this. We're missing this. I think if we combine fatigue and neurocognitive overload, In the heat of battle, I think that's a recipe for an injury. So because of that, we developed the left test, which is one test that can be used. 4 plates are being used. So there's a variety of things. But now I want to segue into our recent research with the neurocognitive testing. So I'm just going to skip that for right now because of time. We've already talked about this. This is the key thing that I want to talk about now. So this was just published in the Journal of Sport Rehab about a year ago. So, and we have a couple of others that are in review. But again, what we did, instead of just doing the hop testing, we added the hop testing, but we added the neurocognitive aspect. So that's the T-drill test. And what we did is we put the blaze pod lights up on the wall in that configuration. We did that because there's a concept called scanning, that when you're playing a sport, you don't just look at one thing. Most of the literature, when you read about their neurocognitive testing, they use one monitor or they use one light. That's not sports because you're looking all over, and that's called scanning. There's actually research that addresses that concept. So we, I guess, serendipitously realized we had to put the lights all over the wall. So again, what we did is, here's the data. I'm not going to bore you with that right now. You can look at it in the literature. So what we did is, this is our next generation. We looked at the traditional T-drill hop tap that you saw. Then we did the neurocognitive reactive T-drill. You'll see that with each of the videos. They had one light came on, red light first, they went to the right. That was their reaction. Green light came on, they went to the left first. Then we did the neurocognitive multisensory recall T-drill hop test. So they did the exact same thing. The first light, right, red, right, green, left. But then they had to look at each of those lights that came up in a random order, and they had to tell us the colors. All right. So first one, we just saw this. It only takes 10 seconds. That's the traditional T-drill. So we timed that to see how long it took. And this was all randomized, by the way. So again, any study, you randomize things. All right. Then the next thing we did is the reactive test. So watch her. The light, if it goes red, she'll go to the right. If it's green, left, she'll go to the left. Watch. Green, she's going to go left. We timed that. All right. What we found is when they had to use the neurocognitive reactive test, and I think we had 40 subjects that were in that article. I forget the exact number at this point. But at any rate, we found there was a 5% decrease in their performance. All right. Next, as I mentioned, this concept of scanning. It's something out of the sports science literature. I was unaware of that, to be very honest, until the last few years. And they've shown with several sports, ice hockey is this example, if an ice hockey player does well scanning, looking at the puck and looking at the other players coming down the ice, they basically, they do well in the scanning testing, their performance metrics are better in every category. So that's an important concept. As I said, I didn't even know about that test when we started doing our testing. And now I use that as the rationale as to why we put the blaze pod lights all over the wall, because somebody doesn't need to look at just one monitor, but they need to be looking all over the wall. All right. So with that, here's a hockey goalie. So, a soccer goalie, football goalie. He's looking at the ball, but he's also had to look at the other players simultaneously to see if there's a pass or whatever. So with that, here's the example of somebody doing the multisensory test. So watch the lights.
Video is on.
So the first light, they'll go right or left. So she's looking at all those lights. Now, when she gets back to the end, she had to recall which light lit up in what order. Okay. So that's the neurocognitive T-drill recall. So just like the concept of scanning. So what we found here, again, one more time, just so you can see it from the back.
Video is on.
First light green, so she goes left. But now watch, the other lights are coming on. Then she has to recall those lights in the proper sequence and
Video
order.
is on.
Okay? So what we found then is when they did the neurocognitive reactive multisensory, it was another 5% drop. Meaning, whenever we start adding things, true ecological validity of sports, that it becomes a minimum of a 10% performance drop. So again, that's an interesting concept. So again, the other thing is limb symmetry is the same when we do those. We also did that testing instead of hopping, which nobody does in a hop test. So nobody does a hop in sports. So I'm talking about the importance of ecological validity. And the whole test that I'm just talking about isn't really ecologically valid because nobody hops for the testing. So the next logical thing is to repeat the test running. We did that for that study that's listed there on that poster, but let me just continue. So there's the summary. I'm not going to belabor that right now, but this is what we're doing right now. We're doing it running with the fatigue condition. So we're combining the fatigue, neurocognitive overload as part of it. So we're using a prospective crossover design, randomized non-fatigue versus fatigue, power analysis, 3 tests, etc. Repeat it. So here's what we do. They did those tests you saw running. Now we have the patient fatigue. And there's certain criteria we use. They got to keep up with the metronome. We can't do compensations. They have to do full range of motion, etc. So again, then they do the test. And again, those lights, he does the T drill without any of the lights. Now the T drill with all the green came on. So he went to the left side first. So he did it first without fatigue. Then he fatigued, as you saw. Then they do it with all the lights coming on. So we just started that data collection literally a week or so ago. So we don't know the results yet. I'm going to speculate that a similar thing is going to occur, but we did the original testing, non-fatigue. I think the results, again, this is our hypothesis. I think the results are all going to drop, but I'll be curious to see how much they're going to drop. So at any rate, that's our next iteration. And then we have some other things planned after that using strobe glasses, etc. So again, looking at those previous, that's one of the other categories we're going to look at is look at people that have had previous injuries and they've been cleared to return to sport. So for specificity, bottom line, they need to get back on the pitch or back on the field. And here's just one study. Again, this is an OJSM, which is an open access journal. So you can get that journal free. Just go to it today and you can get it free access. But here in the center column, they talk about some of the field tests that they use. But the article here, reduction in re-injury rates following implementation of return to sport testing. So again, we have to do the testing. Test, don't guess. And there is evidence that shows that we do prevent the injuries from occurring. So here's another one, return to sport test. Do they reduce the risk of re-injury after ACLs? Yes, it does. Shows the same results. So again, it shows that, again, our records show that passing return to sport testing after an ACL could guarantee the absence of re-rupture in the medium term. I'm not sure I'd use the word guarantee. It may decrease it, but the point is, here's a couple of recent studies that all show that by doing the test battery, test don't guess, by using the test battery, we can prevent the re-injury. Yeah, but here, I want to, last few slides here. What do we really want? Again, yes, we want to prevent injuries. Yes, we want to play better. Yes, we want to enhance performance. But really, what does the coach and the player and the team and the parents and the the all the spectators, what do they really want? The W. They want to win. They want to win. So how does that relate? Well, here's an article by Holly Silvers that high compliance using the FIFA 11 injury prevention programs not only prevents injuries, improves performance, etc., but it actually translates into better win-loss records. And that's what everybody wants. So here is the key. The high compliance is the key, translates into more wins. And she used huge numbers. We look at that, 670 players in one cohort, the control group, 850 in the experimental group. And one more time, those who did the FIFA 11 were compliant to it showed more W's. So my take-home message again with functional testing is test, don't guess. And again, it doesn't matter which test you use. Again, there's normative data available in the literature for all of those, all the different functional tests. There's many, many tests that are available. So to summarize all the information that we started with on ACLs, all the way from the very beginning, from the exam to the mechanism of injury, to the surgeries, to the phases of rehab, to the criteria for return to sport. Again, remember, return to sport's a continuum. Return to participation, most people do that. A few people return to the sport, and very few people return to the prior level of sports performance. So again, that's what we have to do. It takes a team approach, and we have to look at that neurocognitive testing. That's the missing link right now in the literature. Definitely for lower extremity, we're doing lower extremity, and we're also doing upper extremity. It's even the upper extremity is 20 years behind the lower extremity. But that's the area that we're focusing our research. And I showed you we're doing now the lower extremity running T-drill test, which is more ecologically valid than a hop test. But now we're starting to add the neurocognitive overload along with fatigue. And then we're, as I said, we'll eventually add the stroboscopic glasses, et cetera. So there's certainly an evolving landscape of knee care, but we've got to start adding this new neurocognitive testing and return to sport as part of it. Still the sports physical therapy, what I started with, to me is still the greatest profession there is, and still a lot of fun. Again, remember functional testing, the first three letters. And again, it's my 60th year doing this stuff since I started as a student athletic trainer, and I still find it fun with the teaching, the research, clinical practice. So as I said, for the 60 years, it's got to be integrated approach for testing and rehab. Closing message, reverse ABCs. Conceive it, believe it, achieve it, and you will be successful. So there it is. So with that, congratulations to Streak for what they're doing is providing continuing education to everyone. And I'd like to thank you for your time for that. And again, I do have the question there, but I'd like to, because we're running out of time and we have 20 minutes, let me run through the hamstring and then I'll just open it up and I'll stay as long as necessary to answer any questions on anything that we covered. If that's okay, Amar.
Yes, of course.
Oops. Okay. I need to hit this, but the screen sharing and stop is in the way. How do I get rid of that? Can I move them?
I didn't understand.
Okay. On my screen at the very top, it has your screen sharing and stop sharing. Because this is in a protected view, I need to hit something that's underneath of that, and I can't get rid of it.
I
How can I
think
get
enable editing.
I'm sorry?
The same line, there is enable editing.
Where do I do enable editing though?
Protected view in the same line. It
Okay.
says
Yes.
enable editing.
That's what I'm saying. The enable editing is underneath of the screen sharing.
Oh,
Top of mine, it has screen sharing. Underneath of that is the enable editing. I can't move the screen sharing slide. How do I get rid of that screen sharing?
I have no clue actually, but maybe you can cancel the screen shares and reshare the screen after enabling the.
Okay, I'll stop sharing. Okay. Go back to share again. Oh, darn it, same thing happened. Protected view, enable editing. Okay, maybe I got it. Okay, I think I got it. Okay, we all right?
Yes.
Okay,
Oh,
I'm going to go pretty quickly. So I'll apologize for that, but in the last 20 minutes, I just want to get through the whole thing, and I have an interesting case at the end there, and then I will stay as long as necessary for questions. So, but once again, the objectives are listed. They're in your handout. I'm not going to belabor it. But hamstrings are one of the most common injuries, high rates of recurrence. That's one of the problems. And I think part of the problem is there's a misdiagnosis, particularly when there's a misdiagnosis, it delays the treatment that needs to be done. So it's going to create some strong clinical reasoning. As we know, most of the hamstrings are biarticular muscles, though the biceps femoris, again, is the most commonly injured one, and that's the one you'll see on the case. And again, that sometimes patients will complain of some neurological symptoms or something. The reason is obvious that if the hamstring is injured, it's close to the sciatic nerve. Sometimes you'll get some of the neurological symptoms as associated with it. Anatomically, we all know they're the locations of the attachments. And again, that all just goes back to our anatomy. And again, with the proximal injuries, we can have the actual myotendinous strains there, or you can have a tendon avulsion from the actual ischial tuberosity. Even though distal injuries are less common, it's the muscle bellies, and there's different variations of that do occur. Mechanism of injury, again, it's usually a forceful hip flexion with knee extension. So usually high velocity activities. And that's why when you see some of the exercises we'll be doing, that we have to involve some of the faster movements. Like I showed you on that one lady where she was doing some of the hamstring flexion against the ball and she was doing it, as I said, with faster movements, because most of the mechanisms of injuries occur at faster movement patterns, and most of your sporting activities occur at faster movement patterns. So just doing slow controlled velocities are not effective. We have to try to replicate as best we can faster movements. So again, that's important. That's the mechanism of injury. We got to replicate that in a safe, controlled environment to try to minimize and mitigate re-injuries. So again, the other thing that's important, a lot of those loading patterns are eccentric. So that's why the Nordic hamstrings and all that are very, very common. And you'll see some examples of those as well. Now, when the injury occurs, the immediate concern, again, is it's usually traumatic, obviously. What's the patient's ability to weight bear? And then have they heard a pop and or not? So we look at the posterior thigh and we can, again, see things. Obviously, you see initially, then later you start seeing all the visible ecchymosis and all that. You may actually have a palpable defect there. And again, a retracted muscle belly may occur. And obviously, they're going to have significant weaknesses with knee flexion and hip extension. So if that's the severity of it, you need to refer them quickly, because that's usually a surgical case. Not all the hamstring strains are surgical cases, though. So, but that is an example of one that would be. So acute presentation, again, maybe the surgical case, painful pop, bruising, stiff-legged gait, difficulty sitting, maybe some sciatic nerve because of the swelling around the hamstring tear that creates the fluid pressure onto the sciatic nerve. Gradual, again, that's where they're going to have gradual increasing pain with activity, generating forces, and that's where it interferes with their sport performance. How do you evaluate it? So again, part of the evaluation is knowing what we just talked about, but palpation actually helps. And again, Palpation helps us with the localization of the injury, and that may help with the prognosis or the estimation of time. More proximal pain closer to the ischial tuberosity, typically, I'm generalizing now, but the longer the recovery time. The length of the tender region predicts time to return. The width does not. So when you palpate, again, if it's close to the ischial tube and you have a longer feeling of tenderness, that's problematic. Whereas if it's in the more muscle belly, it's not very long, but it's a little bit wider, then that patient is probably going to do better. Now, there again, generalized clinical pearls. So, but again, and the purpose of that is you can sort of map the severity of the tenderness relative to the total muscle's length. And that may provide you with some ideas relative to what's happening. Classification, again, obviously, as we all know, a mild strain is partial tear. Mild injury is a few fibers. Grade 2 is a partial tear. Grade 3 is an actual total rupture. Again, additional risk factors. Previous injury is by far the most common, but some others would be age, other injuries, unilateral ratios, flexibility deficits, poor, and I'm going to say instead of just pelvic, total leg strength deficits, and proprioceptive deficits. So again, flexibility, if somebody has significantly limited flexibility, that can lead to limitations of the flexibility of the muscle, hence making it more vulnerable for injury. Neural considerations using the slump test may give you an indication that they have some swelling that's actually basically also affecting the sciatic nerve. Strength testing, again, tested in multiple angles. Again, if you don't, early on, you want to use a handheld dynamometer as illustrated, and you would test it in different positions. There's a lengthened test there, of course, which you would wait. You would start in mid-range first and progress to that. And then you can either internally or externally rotate the tibia to bias the hamstrings for the testing to see. And again, you can do that to get an idea. Can do handheld dynamometry, isokinetics if it's available. Strength asymmetry may be an indication, again, as a risk factor. And you could look at the eccentric weaknesses. Again, total leg strengthening or total leg assessment. So again, as we said, lumbopelvic testing as well, and looking at the Gmax and the hamstrings as kind of a synergistic component together. So again, and if you have weakness of one, it may affect the other. If you have strengthening of the one, it may inhibit the other. So your differential diagnosis, these are all examples of things that may be implicated with a hamstring strain, either in conjunction with or in case of, again, it may not be a hamstring strain, it may be one of these. So there are just a variety of things that need to be included in your differential exam. Imaging, obviously, your MRI is your gold standard. Ultrasound can be used. And again, PT, again, if they're experienced, may be helpful. So there's just an example of an avulsion at the ischial tuberosity. And again, the retracted tendon is where the star is. So that shows the mass of the retracted tendon. Longitudinal ultrasounds may be helpful. And again, unless you're experienced with doing that and or reading it, then read the radiologist report. So takeaways. Hamstring injuries are common, not trivial though. Proximal tendon avulsions are serious. They may need surgical repair. History and mechanism drive your decision making. That's where your palpations and your mapping gives you an indication regarding the severity. Prior injury is the strongest risk factor. Address proximal control, so total leg strengthening, not only core, pelvis, hip, but the whole total leg strengthening. And again, if you miss a diagnosis, there's longer consequences. There's a few references, and I'll just finish up here the last 10 minutes with this case. So the case study, again, there's the muscle groups. So you see the long head of the biceps, which is the one that's involved with this patient. And it's going to show you some of the exact exercises we're doing. So again, there's the British classification of muscle injuries. So this guy was actually a grade 3, as you'll see. So there's your classification, grade 1, grade 2, grade 3. So he was a grade 3 long head of the biceps rupture. Okay, so there again, grade 3 rupture of the long head of the biceps. So that's a kind of a graphic picture of what happened. Okay, so what was interesting, I just returned literally a week ago from the isokinetic isokinetics return to performance football medicine conference. Great conference. Anyway, they had a presentation there on internal and external hamstring factors. And that's pretty much what I just referred to as some of the causative factors, but that just reinforces them. So patient, 20-year-old male triple jumper on the track and field team, no previous hamstring injuries, performing a triple jump, and on the eccentric landing, switching to the concentric push-off, patient said he felt a pop in the back of his right leg. Patient was examined by the docs. I didn't see him at that time. MRI confirmed grade 3 strain, so a rupture, long head biceps, which we know is the most frequently injured distally because of the dual innervation long and short heads. He was referred for PT to me for an exam and rehab at 1 week post-injury. They were the MRI findings. I can't tell a whole lot from that, frankly. So subjective exam was non-contributory. History, no major musculoskeletal injuries. He did have a history of a mild Achilles tendinosis, but what was interesting, we played high school football, he had 3 concussions, but he was a junior now in college. He hasn't had any of those. Pain you can see there. We didn't do any aggressive activities, so that was non-significant. Observation posture, non-significant swelling, mild antalgic gait, limb length the same, anthropometrics pretty similar, related referral joints, meaning hip, SI, lumbar spine, ankle, subtalar joint, non-contributory, neuro, regular bounce tests, no problems. But when we did, or neuro exam, no sensory problems, no radiation symptoms, anything. We did a balance test, he did fail it. And again, I think that was more due to the history of the 3 concussions. Palpation, he did have a pain over the posterior area and a small palpable lump. Active range of motion, you can see he had pretty much full range of motion, but then when we did the hamstring flexibility test, he had about a 20-degree limitation of hamstring flexibility. We didn't do any manual muscle testing at the first day. He's only a week out because of the pain and no functional testing. First thing we did is obviously phase 1, protection early motion, modalities, passive range of motion, submax multiple angle isometrics. So again, there's examples of your submax multiple angle isometrics. You can do those in different positions. We did core and total leg strengthening. One of the things that I like to do in the sagittal plane, and we started with double legs. I'm just showing the single leg. So this is sagittal plane. So he's getting hip extensors or posterior chain on the right side. He's getting left side. He's getting anterior chain because he's doing basically a straight leg raise, core stability, and he's getting ab work. Then we did frontal plane, again, lateral planks, both legs, both movements, so abduction and adduction. Transverse plane, again, we did some small TheraBand for external rotation on the top, internal rotation on the bottom. Weeks 4, because I'm seeing him now, he's about, I think, 10 or 11 weeks out. So weeks 4, this is what we did. Normalize gait, increase range, begin loading the scar tissue, early strengthening, and cardio. So again, we continued with from a double leg bridge initially to single leg bridge. We started doing double leg hamstring curls to single leg hamstring curls. Then in week 7 to 9, we started intensive strengthening. So we started single leg bridges. We did eccentrics. So double leg up, flexion, single leg down. We started some Nordic hams and RDLs. So here, once again, the important thing here is we did double leg up, single leg down with external rotation bias. One more time. Double leg up, single leg eccentric with external rotation bias. Okay, then we did some soleus work. Okay, we did the lateral gastrocs. What we did with the lateral gastrocs, and this is an important point, we'll internally rotate the foot, the leg. When you internally rotate the leg, that biases the lateral head of the gastrocs, and that's your primary dynamic stabilizer to help with the lateral hamstring that's missing. Furthermore, as you can see, we actually did that, and I'm going to do it one more time. We're doing it on a power plate, which adds perturbation training for the proprioception and kinesthesia. So again, this is early on. He's starting to do this. So internal rotation, perturbations for the lateral head of the gastrocs. All right. Then we did knee flexion exercises, again, progressing. Then we did some lateral step ups, again, looking at the RDLs. We did it on an unstable surface. And again, because of his concussions, I think that's why he didn't do real well. So I had spotters on both sides. So he's kind of wiggle. We started on the floor, so we started with a stable surface. He did okay, but I wanted to start increasing the difficulty of it. So again, we talked about this before, so I'm not going to belabor it. Now doing some of the Nordic hamstrings. So we can do this in different angles and having him do ball rolling. So his hamstrings are in a certain length and position and doing the ball rolling. And we can flex the hip more or extend the hip more to change the length tension. This is one of my favorite exercises for the hams. So here you're getting the gluteus maximus and the hamstring simultaneously, similarly to doing what we did before. So you're doing kind of a fast movement. So he's getting abs at the same time. Fast feet drills. Lateral bounders. Getting the co-contraction and stabilization. And this is where we are now. As I said, we're at the 10-week mark with him. So there's some examples of some of the progressive exercises that we're starting to do with him as we progress along. So I know I hustled through that and I apologize, but I just wanted to share that last little piece with you so you could see some of the exercises we were doing. You saw some of the previous videos of the layering concept. Don't forget that. So my take-home message now, test, don't guess. Think of your layering concept in rehab using your clinical reasoning for your decision-making. So with that, again, one more time, thanks to Streak PT. And thank you all for your kind attention. I know 4 hours is a long time. Thanks for being troopers and hanging in there. Let's now, Omar, let's take some questions.
Okay, I'm monitoring the chat box in case there's any questions.
In your handouts, you all have a lot of references. So again, if there's something you were questioning, just go back to that part of the handout and then go to the articles that I had there or the references at the bottom of the slides. And you can get those articles or references yourself, and you can follow up on that information to see what you want to know more about. So,
Yeah, there's just one question, and
sure.
wants to know how can an ACL injury be caused due to genetics?
I didn't catch all of it. How's an ACL do what?
How can ACL injury can be caused due to genetics?
Oh, good question. I think it must due to somebody's genetics, but that has been shown. There's several articles that have shown that again, if you have a sibling or if you have parents that have had an ACL injury, then most likely you as the individual will have an ACL injury. And I think part of that is frankly due to the anatomy. So again, typically children have similar anatomy to their parents. So with females, again, if they have a narrow notch instead of a U-shaped notch, that's going to make them more susceptible for an ACL. If, as I mentioned before, if the tibial plateau is more than 12 millimeters of a tibial slope, that predisposes you to ACL injuries. So if mom or dad anatomically has some of these things, more than likely the children will too. That's genetics. And that's well documented now that the genetic factor plays a significant role in injuries for ACLs. So kind of frightening when you think about it. If your mom and dad had ACLs and now you're a kid, you want to play sports, it's thinking, oh boy, what do I do? So I don't know. I think it's a ways away, but with AI, that might help us. But maybe doing prophylactic surgeries, notchplasties or tibial slope osteotomies. I don't know. Man, oh man, it's something to think about for the future. What do we do? But I think it's based on just the genetics and the anatomy that happens after parents who've had those problems. They usually have pre-existing anatomies sometimes that predispose the kids to a similar injury.
Yeah. Um, I actually I see no questions so far.
Okay. Well, as I indicated, for anyone who's on the call still, if you still have any questions, you can either contact Omar or Basma. Both have my emails, and you can contact me directly via email. I'll be happy. Don't expect an answer the next day. I'm very busy doing a lot of things, but I promise I will try to get to your email as soon as I can, and or I'll send you information. But as I said, I tried to include a lot of references throughout. So if it's not the heading of the article, on the bottom of the slides, I have a lot of the references listed there. So again, if there's something that you choose to follow up on or want to know more about, then you can just go to those references. Or if whoever just asked about the genetics, go to your PubMed and start typing in ACL injuries due to genetic problems and see what information you get. So, but there's plenty of resources now with all the literature that's available to us. And with a snap of your fingers, you can find almost anything you want. But again, in summary, I'm very honored and privileged that to be invited. And I hope everybody at least picked up a pearl or two out of the presentation.
So that brings us to the end of our course on ACL and hamstring injuries. We've just seen a masterclass in why an integrated approach is so important. So the most important lesson today is a simple one: test, don't guess. By using objective numbers and the testing algorithms Dr. Davis shared, we can provide better, safer care for our athletes. Sincere thank you for Dr. George A. Davis for sharing 60 years of wisdom with us today. It's truly an honor to learn from a legend of our profession. So for everyone watching, thank you for joining us today. If you need to claim your certificate, the registration link is pinned in the live chat on YouTube. Make sure you grab it before you leave. Thank you for choosing StreetBT, and we'll see you next time.
Thank you all again, and thank you for the great summary.